And if I do give the supratarsal steroids in some way, I would definitely check the IOP in a week and again in a month's time to see how that changes. So the supratarsal injections, we know where exactly it's given. I do mix a little bit of dexamethasone also for a quicker action. And I feel that most kids within the first week, they see remarkable improvements in their symptoms. Now, the take home message is that, look, allergic conjunctivitis is a very common and a mild, but on the other end of the spectrum, it can be very, very debilitating and it can be blinding too. So you've got to treat fast and hard. And I again, to emphasize the point where I feel where we may mostly make the problems we have with VKCs, we don't treat it hard and fast enough. We wait until corneal changes, then we start thinking about everything else. Steroid sparing options are very, very important. And very recently in Sri Lanka, at least, we've got the authorities to clamp down on pharmacies, and that steroids have to be given on a updated prescription from a doctor, and it cannot be repeated. And that we've got going as well. So we've got to severely, severe VKC, we've got to aim for quick relief and long-term control. And you cannot forget the quality of life. I mean, this is not as a bigger problem that the patients see as even things like cataracts or even strabismus, but can really impair a good quality of life. So thank you very much for your attention.
Ramra, for a very interesting talk, and you have covered a lot of good points. Only thing I wanted to ask you,
Sure.
that Sri Lanka is quite close to the equator. So
yeah.
does it spring catarrh in your country happens around the
No,
year, or it still has seasonal variation?
Very hardly seasonal. It's just there all throughout the year. It's just at one level. Yeah.
That's what I'm saying, because you're quite close to equator.
Equator is warm throughout. We have got no seasons.
Yeah. So, and I think what you rightly said, it's better to catch them young. Once they get bad, it becomes very difficult to get things back, rather not let them happen.
Yeah. Prophylactic lighting. And so, what about over here? Tacrolimus, are you using it a lot, or in VKC patients?
We are using, but for most of them are treated with steroids only, and quite often the treatment is started a bit late. The diagnosis is made a bit late.
Okay.
They go from one doctor to another doctor, and there is a practice of prescribing steroids without proper indication. So all those issues are there. So by the time diagnosis is made, at times things are quite advanced. So it becomes more.
Yeah, but I found that I've been using this tacrolimus for a few years, and it's really, it made a big difference.
Yeah.
I think the important thing here is to convince the parents that, you got to use this. It's not like the supratarsal steroid injection. After you start using that, at least 4 weeks to 6 weeks, you got to tell them that this is going to take this long, but once it starts working, you really avoid these acute attacks, and it works quite well. Initially, there were lots of reports saying, there was a concern where parents Google tacrolimus and they talk about causing cancer and liver problems. And now a lot of studies telling us that, topical is really not a problem. But I think it really works. Cyclosporin, do you have, what are the concentrations in India? Do you have the stronger 1%, 2% cyclosporin as well?
I think we have weaker concentration.
Yeah, because I found that we have Restasis in Colombo, which is 0.05%.
Yeah.
And has, by the time these patients come to me, there's no effect whatsoever. So I've just gone straight. So in most patients, I've looked at the charts for the last maybe year or two. They come, they're bad, EUA, suprasternal steroid injection, and then you start the tacrolimus straight away. Even just after post-op. The only thing I would speak about is that if you put the tacrolimus in when the eye is in an acute condition, it causes a lot of stinging and it can be very uncomfortable. For that reason, I would suggest maybe even starting off with a very mild steroid for a short period, just to get the child comfortable, just to start the tacrolimus when the child is comfortable, and then they tolerate it really well. And I know we still use the dermatology cream. That's what's available, and it works well. It works well, and that's what a lot of papers have shown, that you don't have to wait until the ocular ointment is passed by your local authorities. The derm cream is generally good as well.
That may take very long. And
Yeah.
How do you withdraw them once you want to taper the treatment?
Yeah, I taper it up. I start with maybe twice a day, and then even twice a day generally works really well.
Yeah.
I've had a few children now on it for maybe almost a year or two, and then I try. I mean, if I really reduce it, but I would rather have them be on it, and then until the VKC sort of burns out itself. I mean, by close to puberty, hopefully it burns out, and then I would again work my way down, where I would introduce a combination of a master stabilizer with antihistamine, and then reduce the tacrolimus gradually. And
So it's a long-term process.
oh yeah, I mean, I've told them it's a long-term thing, and there's nothing we can stop to avoid this, but you've got to sort of keep it under control. And I think it's much better, I feel, overall, keeping them on long-term tacrolimus rather than having, when they get better, you reduce it, then it goes back, you reduce it.
Yeah.
And then, and also the immunologist will be able to tell you more about how how their body is responding, and then you can use that as a deciding factor as well.
And some of this condition improves as the child grows older,
does,
and
yeah.
so
I
that's
mean,
another thing.
and
Natural course.
And it's that very young age where it's dropping, they won't let the drops go in. And I found that sometimes I talked about the quality of life is where you may have very mild disease, but sometimes parents are and the child's okay, the vision's okay, but they're rubbing and rubbing and rubbing it, and that really causes so much anxiety in the parents. And you've got to factor that in, and especially if you've got I mean, most parents are a bit always parents are generally, as definition, more anxious than not about their own children. And when you have this, and if they get very anxious, I mean, at home, when you speak to them, it's very uncomfortable. The mother is shouting at the father. It's very tense in the environment at home, which makes it very difficult to sort of manage,
Because they're always rubbing, always watering.
Yeah, because they say
so it's a constant problem.
The constant problem. And I mean, what I've noticed is that when I speak to parents, it's not like even having a cataract, where you may have severe amblyopia, but the child's doing everything fine, comfortable.
No acute symptoms.
No acute symptoms. So with this is one thing that a severe condition in pediatric ophthalmology, I say that it causes acute conditions, symptoms. As a result, the quality of life at home for the family itself can be really severely affected.
So there's a lot of issues which could be psychological
as well. Yeah, much more than just eye issues.
Yeah.
How often do you send for allergy test in these children?
We do. We've got a basic allergy panel that we can do. It tells you what you can avoid. I mean, of course, there are certain things that you can. I mean, we commonly see, maybe things like shellfish. There are certain things you can avoid. And that gives you, and quite a good number of parents can use that information and say, okay, fine, let's avoid these certain types of food and exposure. But a lot of it comes, as dust mite and pollen and stuff like that you can't really do much about. But I definitely, I mean, if I see a severe case of, I mean, even a moderate case of, I would say pediatrician, I'll get in touch with the pediatrician and the allergist and the immunologist and get them to follow it. I mean, most of these kids have other allergies as well.
Yes.
So you need the pediatrician in the process as well to follow them up. In Nepal, is it VKC? Is it a common thing?
It's very common. Yes.
Common, yeah.
It's common, and it's the same problem. Like, but we have not used tacrolimus.
Yeah, it's something
I
that
can think of. Yes.
I mean, it's something that you should really try and see it.
We have cyclosporine, but weaker, like saying.
Yeah, it's a point.
Usually,
good number we manage with steroids, I think, in our country.
Sometimes we have to
A few
use
cases, I think, which need to be.
and stronger steroids also. I have to use sometimes.
Yeah, it depends on how prolonged that usage will be, and I find that this to be quite a
Long process.
It works quite well. Yeah. Thank you very much. Thank you.
Thank you, Dr. Amila. Now with the next talk, your talk.
Yeah.
Okay, the next talk will be by Dr. Srijana Adhikari. प्रदीप यहाँ आ जाओ नहीं यार she'll be talking about pediatric cataract surgery in difficult situations. She doesn't need any introduction. She's a leading ophthalmologist in Nepal, and she's very active in our organization.
Really sometimes be on not to use steroids at all is what I would also like to do, because once you give them that steroid and they feel so much better,
It's a miracle drug. Steroids are a miracle.
Steroids should be prohibited.
Yeah.
You start with, that's what I said. You see the corneal changes, I'll give a EUA, give the suprachoroidal steroid. Don't get them hooked on the topical steroid.
Yeah.
Measuring IOP in children is not easy.
Yes.
So I think you have to be.
Very careful with that.
Parents are not okay with the concept of putting the ointment in the eye. Regularly sometimes just rub on the lips, just
The
that.
only thing
That's how I think it started, you know, I mean, that trickles down and it helps, especially if some of these kids have got dermatitis as well on they have. But otherwise,
When the child is sleeping, it's much easier to put ointment.
I mean, I will just minimize the problems.
लाइव का लिया क्या क्या सेशन है लाइव थोड़ा टाइम तो ज्यादा है नहीं हमने काफी डिस्कस कर लिया इसमें
Only 2 videos I have to, because I somehow could not. What happened? It's not opening. Oh yes, but here
yeah.
why it's not coming here? Why it's not coming in this laptop? It's difficult for me if I cannot see.
And so once you get the control, then eyes quiet, you start. If you start with the eyes
And there is no I mean, I have not been able to make that slide share also. Isn't it? I mean, it's not. Yeah, maybe, yes. Yes, sir, yes, sir.
YouTube पे लाइव करवा दिया है सर
Yes.
यहाँ से हो या नहीं हो भगवान
So उसमें loading में problem is it this one is ready?
yes Which one you
So at the outset, I would like to thank the organizers of Saoposa for making it possible for this exchange that we can have together. Although it's an early Sunday morning and there's a live surgery session going on, so we have less audience. I would also like to thank the chairpersons, Dr. Subhash Dadea, Professor Pandey, and Srijna from Nepal. It's a pleasure, all of you being here. So today, my job is to talk about childhood nystagmus simplified. It's a complicated topic, but I would like to make it a little simplified if possible. So all we know that nystagmus is a regular rhythmic oscillation of the eyes, and it may consist of alternating phases of slow drift in one eye and a corrective quick jerk in the opposite direction of to and fro. It may be sinusoidal, pendular, or it may be a jerk nystagmus. As the classification goes, the one which I'd like to prefer is the physiologic, the pathologic, and the nystagmoid conditions, which is a much simpler clinical classification. The physiologic that we know of is in the form of optokinetic nystagmus, vestibular nystagmus done as caloric or positional postural testing for mostly done by ENT people. The endpoint nystagmus that we may all see when the child is looking on the end gazes, and a voluntary nystagmus which some children are capable of fooling us with. And the nystagmoid movements are the non-regular movements which are falsely called nystagmus by some. These are like the Bilshowski's phenomenon or the convergence retraction or the opsoclonus or the ocular bobbing and things like that. So the ones which we are going to deal with today is the nystagmus in childhood. And for that, what we talk about is, one is the most common one is the sensory nystagmus, which may be associated with poor vision. And we definitely need to do a good eye examination, fundus examination, and an electroretinography at the least. The other group that we'll talk about is the infantile nystagmus syndrome or the manifest nystagmus, or earlier called as congenital nystagmus wrongly. Then the third is the fusional maldevelopment nystagmus syndrome, earlier known as the manifest latent nystagmus. Then the other common, less common is the nystagmus blockage syndrome. Then we have these in the red, the spasmus nutans, the seesaw nystagmus, and the vertical nystagmus. These I have purposefully delineated in red because these are indications for doing an imaging. The rest you may not do an imaging. Acquired nystagmus, all of them will require an imaging. So the basic rule, which I'll say in short, is asymmetric, vertical, or in cases where oscillopsia is present, you should do an imaging. Rest, like infantile nystagmus, we don't advocate imaging. Now, this child who came to us with having an asymmetric nystagmus, we did the imaging, we found there was a suprasellar mass craniopharyngioma. So whenever you have an asymmetric nystagmus, whenever the child is complaining of a vertical nystagmus or an oscillopsia, never forget to do an imaging. If you have a to and fro sinusoidal movements, pendular movements, and if you have to record, then you will get them, these pendular movements on the bottom that you can see. If this is there, you will always have to do a good examination. Vision may be poor, which will be due to some retinal or optic nerve problem. So these need to be investigated from the ocular point of view in detail. So these are ocular conditions in a list of them, which is there from the American Academy of Ophthalmology series. You have to keep these in mind. A good eye examination, ERG, and sometimes VR to corroborate the poor vision. The other variety which we commonly deal with is the earlier known as the manifest nystagmus, congenital nystagmus, or motor nystagmus. 80% of the childhood nystagmus will be in this variety. And nowadays we like to call it as the INS, or the infantile nystagmus syndrome. They are bilateral, conjugate, uniplanar. What we mean is that nystagmus remains in the same plane in whichever direction you see. They worsen on fixation attempt. They improve on convergence attempt. There is usually a null point present. What is this null point? This is a position in which the nystagmus is either least or not at all there. And oscillopsia generally is absent in these children. 2/3 of these cases may show an inverted optokinetic nystagmus response. To start with, these children, when they are born, they will have end-to-end triangular movements, and then they start having a little slowing down of these movements. They become like the jerk and fast components. And by 1 year of age, this sets in. By 2 years, there is a definite head posture which starts coming in. And once the head posture is established by 3 to 5 years, we definitely would like to correct the head posture by surgery. Okay. Now, when we have this infantile nystagmus syndrome, we need to distinguish one thing, whether there is an adduction null or it is a gaze null. Now, this is an important point from the point of view of surgery. So if you have, for example, this child, this video is not. Yeah. So look at this. This child is having a face turn. And the moment I'll cover the right eye, which was adducting, you see that he maintains the face turn. He's still using the abducting eye for fixation. This is the gaze null. On the other hand, if we have this, so this is the manifest latent nystagmus, and what you see here is, look here, he's having again a face turn to the same side. I cover the right eye. Now look, he's not happy because the abduction nystagmus is bad, and he turns his head to the other side. Now this is a very simple test which will distinguish a manifest nystagmus from a manifest latent nystagmus, and also make your point clear what surgery you have to do. If there is an infantile nystagmus with a gaze null, you would have to do a bilateral surgery in the same directions. Whereas if there is an adduction null nystagmus, you have to do a bimedial rectus recession or a bimedial rectus recession with posterior fixations. This is another adult who is having a manifest latent nystagmus. She has an IDS. So now you see the nystagmus is not much because IDS is in fusion. The moment we break this by a Spielman occluder, now notice when the squint breaks, it's gone out now, manifest ho gaya in the right eye. And now if you'll see carefully, the nystagmus also starts worsening. It may take a few seconds. It's not instantaneous, but it will take a few seconds. You'll start seeing now the nystagmus is there. It's beating towards the left side, the fixing eye. The manifest latent nystagmus classically beat towards the open eye or the fixing eye. Infantile esotropia may be associated with the nystagmus in abduction, also known as IENA. That means infantile esotropia with nystagmus in abduction, or the Ciancia syndrome, eponymically. Now, these children have a face turn and they have an adduction null. So what I generally do is, in such cases, in addition to the bimedial recession, also do a posterior fixation on the medial recti in order to correct not only the esotropia of the infantile esotropia, but also the head posture. So this is the post-op, you can see the head posture. Now, the spasmus nutans is a very important type of nystagmus, which has to be kept in mind. What you see here is a child having a little bit of head tilt, torticollis, and he also has an asymmetric nystagmus. Don't forget this. The left eye is beating much more in amplitude as well as in frequency. Again, focus your attention on the left eye. You'll find that it is a disconjugate asymmetric nystagmus much more in the left eye. If this is there, don't forget to image. Imaging is a must in these cases. There are two varieties of spasmus nutans. The majority, fortunately, is benign, which has a normal imaging, but the 20% or 15% cases may harbor a malignant glioma like this child. This was a report from Michael Brodsky in JPOS as recent as 2019, that these need to be investigated. Nystagmus blockage syndrome is a very characteristic nystagmus which has an inverse relationship between the nystagmus and the esotropia. What we mean is that when they have a nystagmus, the esotropia is not there. When they develop an esotropia, the nystagmus is gone. So it's an inverse relationship. Either you have a nystagmus or you have an esotropia. In fact, esotropia is a mechanism to dampen the nystagmus. So if this is there, like in this case, if you see this child, see this now, the moment he develops an esotropia, he will have no nystagmus. Look here. Now this, he has locked the eyes in. Now this is an indication for doing a posterior fixation on the medial rectus. You may not do a recession, but just a posterior fixation or a retroequital myopexy. So examination of nystagmus, as I said, look for the head posture for distance and near. Sometimes it may be different. It may be periodic alternating nystagmus, which may vary from time to time. Look for the type of nystagmus, pendular or jerk, whether it is increasing in abduction gaze. Visual acuity should always be tested separately binocularly, because latent nystagmus will have a worsening of visual acuity when you cover one eye, as you routinely do. So whenever you have done the uniocular visual acuity, then do a binocular visual acuity. And if you find the binocular visual acuity is more than 1 or 2 lines, you need to do a recheck of the uniocular visual acuity, not by covering with an opaque occluder, but by using a +4 or a +6 diopter, which can tell you the individual visual acuity. And when you measure the, you can use a simple protractor and also look for the pan or the periodic alternating nystagmus. You need to give at least 5 minutes to this child while he's viewing a video. Then you'll find that he's switching the head posture from one to the other. If you miss this, you will have a surprise on the other day when you have done a surgery. So non-surgical management, optimal prescription use of tinted glasses, because albinism may be very commonly associated with the infantile nystagmus syndrome. Contact lenses, because high myopia may be there, or high hypermetropia, which is better off with contact lenses. By the way, contact lenses do not have a lasting dampening effect. So there are papers which have said that contact lenses has dampened nystagmus, but this is only transient. Prisms have been used, base out prisms, auditory biofeedback. We did some publication on this, as well as the acupuncture in the use of controlling nystagmus. But these are not going to be used in a long term. So both work, but we have not advocated them as a surgery, as good as surgical procedure. Medical treatment in infantile nystagmus in the form of baclofen has been tried for acquired PAN, and not for the congenital periodic alternating nystagmus. Gabapentin has also been used in cases of infantile nystagmus, published from the group of Gottlob in UK. And brinzolamide has been advocated by Hertel from USA. And we did a study when we were in RPC on brinzolamide. It has a very little effect. Strategies for surgical management is shifting the eccentric null position. So it may be horizontal null, vertical or oblique, and you'll do the surgery in that direction. Artificial divergence, inducing a divergence by a medial rectus recession, is another strategy. Correcting the associated strabismus is the main strategy for manifest latent nystagmus. So if it's an IDS, correct the exotropia. If there is an infantile esotropia, nystagmus abductions, then you correct the esotropia along with the posterior fixation. 4 muscle, horizontal rectal muscle recessions, or the Hertel-Deloso procedures, are also effective, but only for about few months. So when we plan for the Anderson-Kastenbaum procedure, what we do is look for the face turn, and we need to shift the eyes in the primary position. What we do is we are basically, in short, correcting the exotropia in the right eye and the esotropia in the left eye. So imagine that way, that there is an squint surgery being done, exotropia in the right eye and the esotropia in the left eye. The amount of surgery will be decided by the head posture. So if suppose there is a 30 degrees of head posture, which means 60 prisms, you have to calculate 60 prisms for each eye. So for 60 prisms, lateral rectus would have to be done something like 12 millimeters, and the medial rectus has to be recessed by 9 millimeters. These are yoke muscle surgeries to balance because there was no pre-existent squint, we need to maintain the ortho position. So that is the beauty of this surgery. This surgery is usually done about 4 years of age and is very rewarding surgery. As you can see, there are various variations of this approach, initially described by Anderson and Kestenbaum and Goto from Japan. But what we prefer to do is an augmented Anderson's procedure. As I just said, medial rectus 9, lateral rectus 12 for about 30 degrees of null. Now this is a pre-op and post-op. You can see here, and the electronystagmography also shows you the nystagmus pattern has been dampened very nicely. But as I said, beware of the pan. It can cause a reversal of the head posture in cases in which you thought there was no periodic alternating null nystagmus and it was missed. So like this child, we did surgery, she had a reversal of head posture on the other hand. So if you have done an augmented Anderson's, you are safe because you can just do a augmented Anderson's on the other two muscles. And that is the surgery described for pan. That means retroacutal surgeries or large muscle recessions on all the 4 horizontal recti. So if you have started with augmented Anderson's, you have nothing to lose. On the next day, you do the other 2 muscles. And this is what was there, for example, here, pre-op, second day and third day. So she is fine now. So she has the correction, and even if it's a missed pan. So I generally say that if up to 30 degrees, don't do Kestenbaum procedure. Don't do the 4 muscles. If you have done resections, you'll have to do undoing the resections component, and that will be a little problematic for you. So that is a simplified version of complicated nystagmus version. If there is an eccentric null with strabismus, you have to do a surgery for both. So that you have to keep in mind. If there is an eccentric null in adduction and in esotropia and the fixing eye, you have to find out. Nystagmus surgery works only on the fixing eye. Squint surgery can be done on either eye. So you have to first find out which is the dominant eye, because the nystagmus is going to be corrected by that. So if right eye is the fixing eye and I do a medial rectus recession, it will correct both the esotropia as well as the shift the eccentric null. So it's like hitting 2 birds with 1 stone. Vertical AHP, the same principle is there. We would work on the vertical recti to correct the head postures, and the torticollis, that means a torsional head posture, will be corrected by working on the oblique muscles, and that is what we have seen here. It works very well. So as the time is short, I will just rush into this. And the 4 muscle surgeries also work. We published in JPOS in 2016, and as well as the Hertel-Deloso procedures. But as we found, after 3 months, the nystagmus comes back. So it may be only a transient effect. Artificial divergence surgery, as advocated by Spillman, that means do a bimedial recession when there is no ESO. So you are just inducing a divergence so that the convergence mechanism comes in and helps into the control. So the take-home points are cases with definite eccentric null up to 30 degrees respond very well to the augmented Anderson's procedure. That means medial rectus recession of 9 in one eye and 12 millimeters of lateral rectus in the other eye. For more than 40 degrees, you add resections of the opposite muscles. For cases with pan, do a bilateral augmented Anderson's. Cases with fusional maldevelopment nystagmus with squint, correct the squint, and the nystagmus also gets corrected by itself. IENA Scientia or nystagmus blockage syndrome, you need to do a medial rectus recession with posterior fixation. Now, cases with no definite null, eccentric null, or there is no null, what do we do? We have no real answers. We have tried auditory biofeedback, we have tried acupuncture, we have tried 4 muscle supramaximal recessions, Hertel-Deloso procedures, or even the medical treatment, but nothing seems to work very well. But you have to keep on working on this direction. Imaging has to be done in spasmus nutans, vertical nystagmus, seesaw nystagmus, any case which complains of oscillopsia or an acquired nystagmus. So that will be, in short, how do we manage nystagmus. Thank you very much for a patient listening.
Thank you very much, sir, for excellent talk. Any questions to sir?
Sir, there are some patients who ask that there is no squint, there is no head posture.
Correct.
You've got your nystagmus causing your vision to go down.
Correct.
So now in this sort of patient, parents ask me, what can we do surgically to?
4 muscle surgery. That's what we are suggesting.
Okay.
So the 4 horizontal recti.
Okay.
So that will dampen, and these are like supramaximal recessions. That seems to work, but we have found that after 3 months the effect gets down. So I think people are working. I think if you, some of you may be aware, there is the procedure in which the 4 horizontal recti were totally extirpated by Sinsky, the Sinsky of the Sinsky hook fame, the cataract surgeon. He, in his older age, delved into nystagmus, and he did the 4 horizontal recti surgery, which has been followed by his, I think, fellow Dr. R.W. Lingua, who has published some papers, but these are very traumatic surgeries, a lot of hemorrhages there in the orbit. I do not really advocate that.
That shows it's a very difficult condition to treat actually. And
Yeah.
whatever
So-
we are doing is something at the CNS level and we are trying to correct it at the peripheral level.
Correct.
So there would be shortcomings and difficulties.
So I think 4 muscle surgery is the right now the thing that we usually advocate. In
Yeah.
addition, we may also offer them brinzolamide. So that has maybe some placebo effect. The patients are happy.
The same thing. Does that have any effect? There was something.
Yeah, so the Hurtle-Deloso procedure, again, we tried it, we compared it, and we found that effect is not lasting. And I did talk to Deloso himself personally, and I think he didn't want to agree, I think, directly, but he said he's working on some other techniques.
It's
now.
a very vast topic, I think, and somebody rightly said that don't write about nystagmus because you will reach nowhere.
But it
was
is very
Hogan-
gratifying
it was
surgery.
Hogan or somebody, I don't remember.
Yeah.
I think let's move on to other talks because we are running
But it
short
is
of
a
time.
gratifying surgery for those who have had posture, and these children can be really helped. So please do that.
But
Thank you.
initially it is, but how long term, I think it might have its
No,
own
that is very
consequence.
lasting. I
Yeah.
have patients for 20 years now. They have
Yeah,
very-
some of them.
Thank you, sir. So now I invite Professor P.K. Pandey. Professor P.K. Pandey is Secretary, Strabismological Society of India, and he will be speaking on congenital cranial disinnervation disorders. Dr. Pandey, sir.
Chalo. Dr. Pandey, CCDD. हम्म। ये CCDD है मेरा। हाँ। अरे ये तो डॉक्टर सैमुअल का हो गया। हाँ। Thank you, Dr. Subhash, and I thank Saocon for this invitation to interact. I'll be talking about congenital cranial dissociation disorders. As we all know, this concept was given about 20 years back. A lot of water has flown since then. And with imaging and genetics, a lot of things we understand better. Now, what are CCDD? These are abnormal development of cranial nerve nuclei and or their axonal connections. These are heritable, can also be sporadic because of some genetic mutations. There is a primary disinnervation, means that the nerve supply is not there. That implies lack of innervation. And there is a secondary disinnervation, means that something aberrant has gone and innervated. Now there is a variable component of paresis and restriction. Paresis is the first thing to come in, and restriction may be in variable amount. So depending upon how much is the paresis and how much is the restriction, clinical picture may be showing a lot of variability. And there is a host of conditions, about a dozen conditions, starting a good number of them are at the level of the midbrain, like you all know CFUMs, congenital MED, Browns, and third and fourth order palsies and congenital ptosis. Then you have at the level of the Pons, you have MGP, DRS, which is the commonest CCDD, then synesthetic divergence, BSS and ABDS, and AGPPS, another rare condition, but interesting. And then, of course, you have Mobius and Kalman syndromes. So it's a long list with very varied presentation and creating a lot of difficulties in clinical diagnosis. And once in a while, we do encounter them, and we are in. Now, for CNS development, tubulins are important. And whenever there is a problem with these tubulins, we get into a lot of CNS issues. So tubulins can affect CNS and can also give rise to CFUM. So two tubulins which are important to us are TUB3 and TUB2B. So these, the point is that if you have these variants, then you should also look for CNS abnormalities along with CFUM. So this is just showing in short that there can be a lot of CNS involvement in some of these cases, especially with those which are type 3 and type 2B variants. So you should not always look at them in isolation, and they could be including vocal cord paralysis and intellectual disability. All these things can happen. Now, imaging is very important because a lot of with imaging, it has been shown that a lot of fourth nerve palsies and a lot of third nerve palsies are also CCDDs because hypoplasia of the nerve or the nucleus has been shown on the imaging. So a lot of spectrum has widened, and we understand them better with imaging techniques. Now coming to restrictive CCDDs, we have CFUMs and some other, I'll be showing rare ones. Now CFUM is a rare condition, one in about 2.25 lakhs population. So once in a while you encounter, and once you know, it may be a diagnostic difficulty. So it's primarily a neuropathy, not a myopathy. And the restriction which comes is secondary. Primary thing is paresis. It's autosomal dominant, a good number, can also be sporadic. Now, this is a family, 3 generations. You can see the grandfather, the mother, and 2 daughters. They all have the same clinical picture, which is quite stereotyped, other than the horizontal movements may be a bit different. Some could be in ESO, some could be in EXO. But the most important fundamental thing is that the eyes are cast in down gaze. There is inability to move these eyes beyond the primary position. They don't come to primary position, in fact, and there is a chin up position. This is showing one of these girls. You can see that there is eyes just don't move up. There is could be convergence in up gaze, sort of an A pattern which can be seen in some of these cases. And there could be an exo deviation quite often, could be orthophoria, and some of them could also be in ESO. This is showing extortion. In one of these children, other child has intorsion. Now, why it happens? Somebody goes for intorsion, somebody goes for extorsion. Is a complicated matter, maybe because of IR or SO or whatever reasons that we're not going into that at this moment. This is showing type 2. Type 2 means that both third and fourth nerves are affected. So only nerve which is left is the sixth nerve. So eyes are fixed into abduction nail into lateral canthi. So this is very rare condition. It will be seen in Saudi Arabia in consanguineous families. These CFM 3s are quite, 3 are quite rare, and they could be unilateral. So it need not always be a bilateral presentation. This was very interesting presentation. We had right, as you can see, congenital cystic eyeball with anophthalmos, and left eye we have CFM 3. That means eye is fixed in down gaze with IR fibrosis. There was typical coloboma and very high myopia. And he also had cryptorchidism. So this is a systemic problem. As I was saying, these could also have a systemic overlay. So don't always look at them in isolation. This is showing an MED, as we know, with IR restriction with MGP. So some of these MEDs which have IR restriction because of the fibrosis, they have also been classed as CCDDs, particularly with type 3 variant. So some reports are already there. So this part of MED goes to CCDD probably. Now this is the Brown syndrome. You can see in one in the right eye, and left eye has superior oblique palsy. So this can happen together. Both are CCDDs, depending upon how much paresis has happened, how much co-innervation. You may have a superior oblique palsy, or you may have a Brown's. So these are sort of just a spectrum of presentation. This just shows that if there is underaction, if there is a paresis, you have superior oblique palsy. If there is a co-innervation, you may end up with Brown's. So there is a lot of variation in the presentation. This is showing a superior oblique, as you all know. So maybe the superior oblique palsies are the commonest CCDD rather doens. I'll be showing 3 cases of third nerve palsy which had very interesting co-innervation from other nerves, like with other CNS findings. Now this is a boy, 8-year-old boy. You can see third nerve palsy in the right eye and tilt to the right side. You can see the motility. The right eye is not elevating. In fact, it is going into adduction in up gaze, and there is synergistic divergence as the child is looking to the left side. Now this is small video. See, as he beats to the, looks to the right side, there is a jerk nystagmus. In primary position, there is no nystagmus, but as he goes, now he'll go to the left side, you find that there is upbeat nystagmus in the right eye and downbeat in the left eye, and there is a synergistic divergence So this is a combination of SD with a lot of other things. I'll show you something. Now this is right eye showing intorsion in this, and once we make him look up, there is a conjugate change in torsional position. You can see the right eye which was intorted has gone into extorsion, and other eye which was normal has gone into intorsion. So this kind of conjugate torsion happens in skew deviations. So that means there is some involvement of autolytic pathways in this child, along with third nerve involvement and ST. Now this is just showing the pathway for the autolytic pathways. So this, if there is involvement along the pons, maybe this kind of picture has happened. So this could have wider involvement as compared to just the nerves and the nuclei. This is another child, third nerve palsy, right side again, and there is no ptosis. And you can again see the scientific divergence in this child also. And if you look at the video, there is a oculum, there is nothing happens when he opens the mouth, but when he moves it sideways with the external pterygoids, you can see that there is synkinesis of the medial rectus with the external pterygoids. So this is something, and LR also. And when he looks to the opposite side, there is scientific divergence. So this is also very rare presentation, that synkinesis of the mandibular division with the medial rectus in this child. Normally you see MGP, but here this is with the medial rectus. This we have seen. And LR is also probably in synkinesis, because as the jaw goes this way, it is also abducting. Now this is another girl who had very interesting presentation. I'll just take half a minute. She has third nerve palsy, people involving third nerve in the left eye, but when she's just going to touch her lid, and there is going to be elevation of the upper lid, nothing happens to the pupil. Now what is happening here is that probably she's pressing over her lid to the Mueller's muscle, and Mueller's has proprioceptive innervation along with sympathetic. So both this is happening because of the proprioceptive innervation, that she is able to open the lid. Now it's going to come down again with half a minute or so, and there's going to be a lot of copious watering was also there, tearing, and then again she does, and this will again happen. So this was kind of proprioceptive lid elevation we saw in this one. Now another condition I just want to talk about is very short, that something like AGPPS, about 150 cases have been reported, and this just means horizontal gaze palsy, scoliosis, and a lot of radiological features. We'll not go. I'll just show you 2-3 cases. This is an 11-year-old girl. You can see there is scoliosis, which may come later. It may not be present at birth, so it may be missed at that age. This shows the right side scoliosis. There is no horizontal movement, no globe retraction, and there's a vertical gaze is normal, and convergence is also normal in these cases. The problem is with the gaze fibers as they are crossing in the this thing at the level of pons. This is showing that there is hypoplasia. Pupils could be smaller in these cases. And this is showing another girl with accommodative esotropia, about 5 diopter hypermetrope. Eyes were in ESO. We operated. There was not. This is again showing scoliosis on the right side. And we did large MR recessions, and she was orthophoric. But these can also go in ESO, some of these. And another one I'll show you. This is another girl with AGPPS, which was in exo deviation. So they are not always in ortho position. Depending upon other factors, they can also move into ESO and exo. These have to be differentiated from, say, Duane's or Mobius, because they could also have similar presentation. If there's a bilateral DRS, for example. This is showing a 9-gaze picture for that same girl. And this is showing intorsion in such cases, which can be there. So to conclude, these are the CCD should be considered in the differential diagnosis of oculomotor disorders. The recent advances in imaging and genetics have enhanced our understanding of CCDs. Some third and fourth nerve palsies need to be considered as CCDs, and surgical interventions are challenging. Results are modest, and multiple procedures may be required. Thank you.
Thank you, sir, for an excellent talk. Any question? So now I invite Dr. Srajana Adhikari. She will be speaking on pediatric cataract surgery, a difficult situation.
Other day I was working at the same room. Okay. Yes, yes, yeah. Yeah. Okay, I think that should be done. Okay, she will present and then I will. Can I come with you? Yeah. Can I come with you?
Talk, holistic approach to pediatric cataract management, but due to suddenly he has to go somewhere, so Dr. Diksha Rani will be speaking. Dr. Diksha.
Good morning, everyone. I'm Dr. Diksha Rani, a senior resident at Pediatric Cataract and Refractive Surgery in RP Center, New Delhi. I'll be discussing on holistic approach to pediatric cataract. Beginning with embryology of lens, lens develops as an outpouching from prosencephalon that forms the optic vesicle. The eye develops as an outpouching of prosencephalon that forms an optic vesicle, and the lens develops from the thickening of surface ectoderm, which form the lens placodes. The posterior epithelium gets transformed into the primary lens fibers, while the anterior and equatorial lens fibers, they keep on proliferating to form these sutures, anterior suture and the posterior suture. So coming to pediatric cataract, it is a major preventable cause of childhood and visual impairment and blindness in the world, with a prevalence of around 1 to 4 plus per 10,000 children in developed countries and slightly higher prevalence of 5 to 15 in developing countries. These are the various morphologies of pediatric cataract. We can have pulverulent, we can have zonular. This is a sutural cataract, another form of zonular cataract, and a posterior lenticular. So any child which comes to our clinic with complaints of leukocoria, whitish reflex, abnormal movements, bringing objects close to the eye need an evaluation. The comfortable position for examination is a mother's lap or shoulder hold. Look for binocular red reflex, look for any abnormal facies, microcephaly, strabismus, check for pupillary response. A distance direct examination for anterior segment usually tells all the details about the anterior segment. These are the certain pictures. This child has bilateral cataract. This is a typical phenomenon seen in children with very poor vision. They tend to poke their eyes with their fingers, known as oculodigital phenomenon. This is another child in which we can see that the child has uniocular cataract and he has a preference for the right eye. When we tend to fixate the right eye, the child gets uncomfortable, while when we fixate the left eye, the child is comfortable. Another patient, this patient has leukocoria again, but we can see that the glow is from retina. So the lens is clear. This child either has ROP or retinoblastoma or some other posterior segment pathology. Visual acuity assessment for children needs to be done. These are the various methods we have. We have Cartford drum test. We have Icnovis developed at our center by Professor Pradeep Sharma. We have Teller's acuity card and Cardiff charts. Cataracts are usually associated with some of the other systemic association, like we can have Nance-Horan syndrome, and this child has widely spaced teeth, anteverted pinnae and prognathism. Mother has a sutural cataract. This is a clinical picture of the mother. So it is an X-linked dominant transmission. Another child with Conradi-Hunderman syndrome, we can see patchy alopecia, flexion deformity of the finger, asymmetry of the limbs, and a zonular cataract. Down syndrome with flat faces, protruding tongue, mongoloid stance, flat nasal bridge, small chin and a small neck, and cerulean cataract. Congenital rubella syndrome can have microcephaly, persistent ductus arteriosus, and cataracts. Coming to the basic concepts of surgery, the main target is to clear the central optical area, remove the scaffold for PCO formation, maintain the support for IOL, and to insert an IOL, and to give an appropriate refractive correction. So before beginning, we need to, the child undergoes an EUA. Axial length is done using a scan. A keratometry, handheld keratometer is used to capture the keratometry, and IOL power is calculated. We also do a UBM to look for lens morphology, as this picture shows a zonular cataract with clear central zone. Another picture with zonular cataract and a central nuclear cataract. This is a UBM picture of a central nuclear cataract. This is a post-traumatic cataract with partially absorbed morphology. Another picture of post-traumatic cataract with a breach in anterior lens capsule. And this is a case of spherophakia with the lens in anterior chamber touching the endothelium. So doing a UBM gives an idea of what we are dealing with. Now, why a pediatric cataract needs more care? This is because there are unique challenges with this. There's anterior chamber instability, increased capsular elasticity, and decreased scleral rigidity. Also, there is a tendency of visual axis opacification. However, nucleus is very soft and very easy to aspirate. Now, there are various formulas given for axial length, for IOL power calculation, depending upon the rate of growth of axial length by Jahan, Prost, and NID. But these values do not hold true in our Indian eyes. So we, under the, Dr. Khokhar has invented this new undercorrection, which has been well established and gives good results, that up to more than 5 years, we do not do any undercorrection. Till 2 to 5 years, we do around 5% undercorrection, with 5% for 2 years and around 2% for 5 years. 1 to 2 years, around 10% undercorrection. 6 months to 1 year, around 15% undercorrection. And for infants less than 6 months, we give a 20% undercorrection. This is to keep in mind the rate of growth of axial length. The maximum growth occurs in first few years of age. And if we give a emetropic power, will have a huge myopic shifts in eventual. So this is a short video of surgery. After side ports are made, we should always stay in the anterior capsule even if there is good glow, because this capsule is very elastic. So we fill the anterior chamber with a heavy OVD. A small nick is made on the anterior capsule, and the rexus is completed with a long forceps or with a utrata forceps. We can use these guides to size the rexus. These are microscope overlays, or we can even stain the cornea. Hydrodissection is done with OVD still inside the eye, as it gives better cleavage planes. This is followed by aspiration of the lens material. Anterior chamber is again filled with OVD. Do not overfill, as it may push the posterior capsule back. Now a small nick is given on posterior capsule, and the posterior curvilinear capsular rexus is now completed with the forceps. Frequent grasp and regrasp are needed to have a well-controlled and a well-sized rexus. Around 3 to 4 mm PCCC is a good size. So after rexus, we need to do a good anterior vitrectomy beyond the margins of PCCC, 360-degree bimanually all around. This removes the scaffold for VO proliferation. The space between anterior and posterior lens capsule is filled with OVD. We also visualize the fundus on table so that we can give a prognosis to the parents. A single piece IOL then goes in the donut between anterior and posterior capsule, and the trailing haptic is nudged. The wound is sutured, and finally the visco is aspirated, and the side ports are hydrated. This is a general management, but the most important part of managing a pediatric cataract is rehabilitation and post-op care. So post-op medications includes antibiotics, steroid, and cycloplegics. Refraction should be done immediately on day 1, and the glasses are prescribed on the same day. This is to inculcate the habit in parents about the importance of glasses. Otherwise, they might not give the glasses to the children. And in cases of uniocular cataract, patching is to be advised. So these are the pictures. This patient has undergone left eye surgery 1 day back. The child is wearing correction in the left eye, while the right eye is wearing plain, waiting for the surgery. Another adult child, 4 years old child using bifocals. For unilateral cataract, an aggressive occlusion therapy is needed. IATS has advice of 1 hour per day occlusion till child is 8 months, starting second week following surgery, and they advise patching all hours that the child is awake, and every other day or one half of the child waking hours every day. Whereas we either give a full-time occlusion, part-time occlusion, or partial occlusion to maintain binocularity. For children less than 1 year, the waking time is divided in the half, and for elder children, one is to, age in years. Depending upon the age, we occlude. Like for 2 years old child, 2 years the better eye is patched, and 1 year the worse eye, and it goes on till 6 years. And we do not prescribe patching more than 6:1, as it increases the risk of occlusion and myopia. Now, a lifelong follow-up is needed. At one week, we look for a glow, confirm compliance with glasses, taper the medications, and a visual acuities assist. At 4 to 6 weeks, EUA is done to remove the suture and to confirm the power of glasses. Then further follow-up is needed with refraction at every 4 to 6 months. If any poor red reflex is needed at any time, the child should be taken up for EUA, and VO should be cleared. Certain complications may include VAO, like this in this child, refractive surprise, and glaucoma. In aphakic patients, when the white to white is less than 9 mm or axial length is smaller than 17 mm, putting an implant might be challenging, and hence these patients are rehabilitated with aphakic glasses or contact lens. And in cases of unilateral aphakia, it needs to be augmented with patching. A good contact lens for a child should have maximum oxygen permeability, expanded powers, steeper basal curves, and small overall diameter. But again, it is not very practical in our setup. So I would like to end by a quotation that you're not defined by what you are willing, but what you struggle for. So thank you.
Thank you, Dr. Diksha, for excellent talk. Dr. Sinha, are you ready? Okay.
Yes, Dr. Subhash, I'm ready.
You try. It will work. It will work.
Or you can get on the pen drive.
Yeah. Hello, Dr. Seema.
Most of the time I used to present with this one only. I mean, it's the same laptop. But... Okay, I will use yours, right? So last time, let's try. It's okay? Yes. Or the other way around. And then open. Okay. I think it's come now. It's come here, but not there. Back. How is insert? And open the slides now. Okay, it's okay. No, sir, it's not. I mean, showing in that this thing. Yes, yes. I had some videos, just informal. I had some.
Is it something like transmission?
I don't know. Because that's okay. That's okay. Yes. It's not copying also. I mean, many minutes. Yeah, sure. Yeah. That is.
Online वाला करवा दो.
I have my this thing hard disk drive. उसमें save करके.
Hello, Professor Seema, are you listening?
Yes, I am. Can you listen me? Can you hear me?
You are muted.
I'm not muted. I have opened from here. I'm not muted.
So you can start your talk.
Okay, can you hear me?
Your audio is not working.
But I am open from here. Just a minute. Let me see.
I think she is mute.
A moment. Select
Dr.
your mic.
Seema, you are mute. You are muted.
Now can you hear me? Hello? I'm not mute. I've opened from here. Hello? अब क्या हो गया? क्यों हम म्यूट क्यों हो गए? तेरा माइक को कुछ हो गया? I'm नहीं होगा तो उसकी भी नहीं चल रही. माइक तो नहीं बंद गई. Audio setting.
Ma'am, you are not audible. You are muted.
But I am कहाँ से होना ना? वो म्यूट वाला कहाँ चला गया? But
उनकी आवाज इधर नहीं आ रही ना.
I'm not mute. There's nothing wrong with me. I'm unmute.
बेटा ये देखो.
अरे हम तो अनम्यूट है ना? यही है ना? कैसे खोले बेटे? हम तो कोई और तरीका ही नहीं. If I can hear him, they should be
कौन
hearing.
10-15 मिनट थोड़ा सा किया अगर हो जाए तो ठीक है. तब तक चाय वाय पी लो. Hello.
Hello. Can you hear me now? इसको unmute करके unmute करके mute. Can you hear me now? Can you hear me now?
Professor Seema, you are not audible.
There must be something wrong. with your
Kindly show your slides.
Sure. Slide show कर लो बेटे. कर बेटे इसको कैसे कर लो?
Yeah.
Slide show. Slide show कर दो बेटे. मुझे भूल गया एकदम से. मेरा लैपटॉप नहीं है ना बेटे. बेटे को भूल जाता बंदा. क्या कर रही है बेटे? स्लाइड शो में जाना बेटी. वही कह रही हूँ, मुझे नजर नहीं आ रहा. लैपटॉप से करती है. I thought you knew it. हाँ तो मुझे नजर नहीं आ रहा. अच्छा आराम से. Hello.
Hello.
Anji, hello. Can you see my slide? I've done the slide share now.
Kindly share your slides.
I have already shared my slides.
So carry on, carry on.
Can you see my slides?
Yeah.
And can you hear me?
Yeah. Yes.
Okay, so then sir, I should proceed. Okay, thank you very much for the great honor of including me in your prestigious conference. Today, I will be talking about the eye are a window to the inside of the body, which is something very important. We know that it is undeniable that our eyes are a very special part of our bodies and unique to every individual. Eye structure and personality could be linked because the genes responsible for the development of the iris also play a part in shaping the frontal lobe of the brain, which influences personality. Now, most clinicians ignore the involvement of eye in systemic diseases, which we should not. Our eyes not only give us a sense of light, enabling us to visualize the surrounding world, but they are also the gateway to the inside of the eye. A routine eye checkup may reveal life-threatening conditions, and I will just go through a number of cases which I've come across in my life. The most important, if a child comes with you with headache, it is very essential that we should do a fundus examination. And this is a picture of a child who came with a headache, and as you can see, there is papillary edema, and then you should involve a neurologist and get an MRI done, and then he was diagnosed with the presence of a space occupying lesion. Again, this was a child who came to the eye department for frequent complaints of headache. On eye examination, again, papillary edema was seen, but he was referred to the neurologist, and they did an MRI, and no space occupying lesion was found. But however, on doing the lumbar puncture, they could see that there was a rise in the intracranial pressure, and he was diagnosed as a case of pseudotumor. So the hint came from the eye. Then again, leukocoria, which is very important, as we all know, it not only why is it turning by? Not only leukocoria, which is not only I mean, we know that when we take a flashlight and we see a leukocoria, that can be indicative of retinoblastoma, which is a life-threatening disease. And even strabismus is also maybe an indication of retinoblastoma. Then eye can be very can guide the oncologist as concerning about the blood dyscrasias, because there's sometimes the first presentation is in the eye. This is a patient who presented with subconjunctival hemorrhage, and he was diagnosed with having some disorder in the coagulation system. Then again, this is a child who was diagnosed as histiocytosis, and he presented with swelling in the lid, and on a very thorough medical checkup and a checkup with a pediatrician and an oncologist, he was ultimately diagnosed with histiocytosis, and this was the first indication. Then again, this is a child who presented with bilateral proptosis, and again, he was diagnosed with histiocytosis by the oncologist. And as you can see, that we frequently get patients who are suffering from leukemia, and when you do their retinal examination, we can see pictures like that with the hemorrhages and variable amount of pre-retinal hemorrhages and such, and they are indicative of relapse in the leukemia. Then again, the eye can be the first sign of non-functioning immune system. We may be able to, like this is a child who presented with a decrease in the vision, and on doing a fundus examination, she was diagnosed as a case of toxoplasmosis, and then it was referred to the medical department. Then this is a child who had an immune suppression disease, and he presented with herpes zoster, which was non-responding. This is again a child who presented with herpes zoster, and he was immunocompromised. Then inherited metabolic disorders can also be seen first in the, and ophthalmologist helps the medical practitioner in the diagnosis of this disease, such as Wilson disease. As you can see in Wilson disease, KF ring is a very important diagnostic factor, and presence of sunflower cataract is also an important diagnostic factor in the diagnosis of Wilson's disease. Then oil droplet cataract, and this is a child who presented to us with cataract, and this was a typical oil droplet cataract. On investigation, he was found to be suffering from galactosemia, and when his galactosemia, when he was referred to a gastroenterologist, and when the galactosemia was looked into, the cataract disappeared. NIRADIA is also a very sign. If you see a child with NIRADIA, you have to do a KUB done, ultrasound of the kidney, and it may be associated with Wilms tumor. Now, this is a child who is presenting with cystinosis, and the patient was referred to the ophthalmology department for corneal examination, and this cystine deposits are seen in the cornea, and this helps in the diagnosis of cystinosis. Then Alport syndrome, as we all know, there is an association with the ears and kidneys and the lens, and this helps the nephrologist to come to a diagnosis. They usually send the patient to the ophthalmology department to rule out the presence of anterior lenticonus. Then Senior-Loken syndrome, this is a patient who presented with retinitis pigmentosa, and he was diagnosed with Senior-Loken syndrome, which presents with the kidney disorder. The kidneys is cystic and it's got inflammation, and it is known as nephrolithiasis, and they may be associated retinitis pigmentosa or retinal dystrophy, and these patients also have high myopia. Then Usher syndrome is again retinitis pigmentosa associated with the deafness and kidney disorder. Gyrate atrophy is also when you see the fundus, you can see you can see the patient. This is the typical fundus photograph of a child suffering from gyrate atrophy, and there are mutations in the gene for ornithine aminotransferase, and the management in the right direction may help these patients tremendously. Then again, Tay Sachs disease presents with cherry red spot in the center of both eyes. Yeah, you can see this is a cherry red spot which is present in the both eyes along with optic atrophy, and this also helps in the diagnosis of Tay-Sachs disease. Then again, metabolic disorders, MP1, MP2, 3, the patient presents with, it referred to as for, they sometimes present with corneal opacities, and when you rule out, you just have to rule out the presence of rise in the intraocular pressure and have to get the help from a gastroenterologist or pediatric enterologist who would look into them. So this is a patient who presented with corneal opacity and was diagnosed with mucopolysaccharidosis. They have short stature, frontal bossing, kyphoscoliosis, joint stiffness, and thick coarse skin. Then this is a patient who presented with homocystinuria, presented with dislocated lens, and was diagnosed as homocystinuria. Heterochromia iridis is you can see there's a very typical case of heterochromia iridis. They are siblings. And if this is associated with a white forelock and deafness, then it is known as Waardenburg syndrome. Then tuberculosis, sometimes it is very rampant. It is sometimes present in some disease, in some deformity or presence. It presents first in the eye, as you can see in the picture. Then there's sphygmocalcilar conjunctivitis, and in the other picture there is a swelling which was non-responding to every antibiotic. And when these are my 4 patients who presented with the ocular problem, and on doing the Montos checks, and they were found to be positive, and then they were diagnosed with tuberculosis, and when they went onto ATT, these diseases disappeared. Now, this is a typical patient of Shabir syndrome, and as you can see, this child presented with the first presentation within the eye, and you have to involve because they have the involvement of the skin, they have the involvement of the larynx, so there has to be a close teamwork between the dermatologist, the ENT specialist, and the ophthalmologist. Then this is a child who presented. I'm sorry that I do not have a video of this child, but this child presented with invariable deviation of eye, and she had staggering gait, not able to walk properly, uncontrolled body movements, and getting an MRI done. A typical molar tooth sign was seen and was diagnosed as a case of Joubert syndrome. So now a battered child, when a child presents to you and you with such a picture in the retina, then you have to look into the history of the child, and you have to take a very detailed history. And this is a typical battered child syndrome. Thank you very much for your attention.
Thank you, Professor Seema. So, Dr. Simona, are you ready? Chalo. Thank you very much. एक सर फोटोग्राफ के लिए आ जाइए.
म्यूट कर दे. हम लीव बंद ही कर देंगे. लीव लैपटॉप बंद कर देगा. मैं बहुत तेज बोली ना. अच्छा लीव करते बेटे.
So good morning, everyone, and I welcome you all to this uveitis session, the science and the art of uveitis. And since we are already running late, I'll hand it over to our moderator, Dr. Soumya Basu, who needs no introduction, to conduct the session, please.
Good morning, everyone. I'm so happy to see that there are at least 4 or 5 people who are not part of the faculty team today. So thank you. Let us know if you need any refreshments or anything to continue sitting here. All right. So we'll start off with our first talk, and we have very interesting. So the set of talks are very interesting, not usually covered in most uveitis sessions. So our first speaker today is Dr. Mayur Morekar from Bombay Hospital, and he will talk about the art of history taking. Right.
Yeah, so good morning, everyone. And I always start all my presentations with acknowledgements to my teachers. The talk for today is the art of history taking. And I'm Dr. Morekar from Bombay Hospital Institute of Medical Sciences, Mumbai. Now, this talk is divided into 5 sub-talks. So the first one, history taking, the science and the art, because this entire session is called science and the art. So I thought we would put it that way. History taking in medicine is regarded more as a fine art than a science, and it involves more than good communication skills. It systematically unravels the mystery of the patient's symptoms and suggests the most likely diagnosis. Now, why is history taking in uveitis a science? It involves multiple scientific principles and skills, and we all know this part very well. So I will not go into details of this part too much. We all know how different uveitic entities are present in different age groups. So one should know whether the age group is that of the child, whether it's a young adult, whether it's middle age, and whether it's old age. Most times in old age, we don't get de novo uveitic entities. They would be masquerades, but then that barrier between middle age and old age is getting breached nowadays. Gender and the race are 2 other things that one should keep in mind. Certain uveitic entities, as you can see, will have a male predominance, and certain will have female predominance. The race also plays a role. Geographic location is the next important uveitic history that one needs to take. We know that diseases like tuberculosis are more prevalent in developing countries. Now, this one is a little important. Diet, domestic and personal factors are important. History of ingestion of raw or uncooked meat, while considering a diagnosis of toxoplasmosis, history of exposure to sewers, rodent urine in leptospirosis, history of ingestion of unpasteurized milk, and the history of sexual activity and preferences is also a must. We now know that in uveitic entities where we suspect an autoimmune etiology, a history of arthralgia is important. The history of present or previous skin lesions in the form of nodules, rash, erythema nodosum is important. The history of hair loss and the history of the presence of present or previous oral ulcers is important. Lastly, the history of CNS symptoms, headache or ENT systems, auditory, vestibular, and the history of pulmonary symptoms, including cough and breathlessness. Now, this part of the presentation I went in through very fast. In details, one can read it in that reference that has been going on at the bottom from the slides. Partho is here, and that's from one of Partho's paper, Clinical Approach to a Case of Uveitis. Of course, genitourinary symptoms, genital ulcers, hematuria. Now, coming to the main part of the presentation, that why history taking in uveitis is actually an art. It has been reported in literature that a thorough history can lead to a right diagnosis in about 75% of cases, and physical examination is contributory 12% of the time, and investigations only 11% of the time. This comes from the literature of internal medicine. it is worth emphasizing nowadays that technology has a definite place in our patient care, but that place should not be ahead of history and examination. In current times, especially with the younger generation, technology appears to have supplanted clinical skills overall. And as more advances take place in the biomedical industry, this dominance is further increasing. And therefore, it is important for all educators in instruction courses and also in medical colleges to show learners the importance of history taking in solving diagnostic dilemmas and simultaneously to stem the tide of needless investigations to combat the ever rising healthcare costs. So traditionally, this is what we have been doing. We have a tailored approach in uveitis that involves taking a detailed history, both ocular and systemic, doing the examination, including vision, slit lamp examination, fundus examination, and then requesting for appropriate ocular imaging, including B scan, FFA, OCT, and nowadays OCTA, a physician examination, laboratory investigations, and then the treatment. Probably this is what would be a more artistic approach, or probably even a scientific approach, that we initially take a very quick ocular history, then proceed on with the vision, slit lamp examination and the fundus examination. And after this, have a clinical impression and base the detailed history on our clinical impression. And then after that, do a quick systemic examination ourselves, which should be tailored to the clinical impression, and then proceed with the investigations, the physician examination in detail and the lab investigations, all tailored to the clinical impression. So essentially what we are doing is, after a quick initial history and examination, forming a clinical impression and basing the rest all on the clinical impression. So we'll go ahead with one case example. This is a patient who presented to us in May 2022. He was a 17-year-old adolescent with severe redness, pain in the right eye since 5 days. He had been on oral prednisolone with antacids for 3 days and had stopped them a day back. He had been on prednisolone eye drops 6 times a day, hometropine eye drops thrice a day. And initially, he gave no history of any systemic illness or allergies. The initial part of the history is taken by the optometrist and our resident ophthalmologist. After that, the patient proceeds for the slit lamp examination. On examination, the patient had a circumcorneal congestion, small keratic precipitates, and a streak hypopyon. The right eye vision, you can see, is hand movement close to face. The anterior chamber showed an organizing exudate, and there was no view of the fundus. So here we knew we were dealing with what was a severe non-granulomatous uveitis. So we have a young gentleman with a unilateral non-granulomatous anterior uveitis with hypopyon. So based on this patient phenotype, we recalled the patient and took the retrospective history. Probably this is the most important part of the presentation, that once you have a clinical impression, you can and should go back and take the retrospective history. Herein, we asked the patient for early morning lower back stiffness, which he said he had since a few days. Now, this part of the history in the later on talk with the patient, he felt it was not a relevant history to give us initially. There is a second part of the history, which when I was directly asking him, he said that he did have a painful urination since the past 1 day. The next slide has been put in there with the consent of the patient. So then I was very specific in asking him if he had any genital ulcers, to which he actually said yes. And this picture is taken by the patient himself on the day of the examination in the washroom. And then he came and showed me this picture. He said that he had this urethral ulcers since the past few days. And the entire thing had started with the urethral ulcers. We proceeded with the B scan, which showed few mobile vitreous echoes with a marked thickening of the choroid at the posterior pole and no retinal detachment. So by now we know that the patient is a unilateral non-granulomatous anterior uveitis. He is a young gentleman, an adolescent with an early morning lower back stiffness and a urethral ulcer. So we know we are most probably dealing with what could be an HLA-B27 related syndrome. So we asked for a HLA-B27, which was positive. His CRP was raised, HIV was negative. Urine showed about 65 to 70 pus cells. That is a little more than what is acceptable. His HbA1c was normal. The total leukocyte count was raised with a neutrophilic predominance. We then had a thorough review of systems and started the treatment with oral steroids, intensive topical steroids, cycloplegic agents, and immunomodulators, including oral methotrexate. The patient was requested and received a rheumatologic review where he was found to have ankylosing spondylitis. This is the patient in October 2022, comfortable on treatment. He's now on an oral prednisolone at 5 milligram per day. He's been on methotrexate 15 milligram per week, has a best corrected visual acuity of 20/40 N6, resolved anterior segment inflammation. You can see that he has no posterior segment inflammation, but the media appears hazy. That's because of a complicated cataract. So why is there a need to teach this art? This is the last part of the presentation. There is a need to teach because history taking is absolutely the first encounter that a doctor has with the patient. A good history taking is to do the right thing and ask the right questions at the right time, and to do it right to get the clinician to the right diagnostic track. The root of the interaction is the doctor and the patient communication. That should always be a two-way process involving both talking and listening. As Professor Monroe has said, we must be prepared and be able to listen to what the patient is saying and interpret correctly what exactly is being communicated to us by the patient. The body language of the patient must be observed closely. Facial expressions, tone of voice, eye contact, etc. should be taken into account. And in many instances, the body language of the patient is a more accurate indicator of their problem and the severity with which they are perceiving their problem than their whole verbal presentation. This is the last slide, a rather busy slide. Common pitfalls in history taking is the inability to go further than the chief complaint. Too hasty history, throwing out leading questions, not allowing the patient to talk uninterrupted. If the patient is not willing to talk or unable to give answers to prompt answers to questions, then labeling him as someone who is a poor historian. Unable to reconstruct the sequence of events. The sequence of events is important. Absence of perspectives while getting along with questioning. Disregard of the important negatives. Disregard the importance of informants. And unable to master the use of language. Many times the language is important, what we are speaking, and also interpreting the unspoken language to come out with the answers, which many times may be evasive. With this, I would like to conclude the talk. Thank you.
So thank you, Dr. Mayur. I think you've beautifully highlighted the relevance of history taking, which I think in uveitis patients is of extreme importance. Just to add to that list that you showed on the last slide, I would say pay importance to also the attendant who's sitting with the patient. So sometimes they may be very reluctant to come out with the details depending upon the attendant who's accompanying them. So it's a good idea to, again, reinforce those questions in the absence of the attendant once again.
That's the most important point here. In fact, this young gentleman actually did not give me the history of the genital ulcers in front of the attendant. It was only when he was moving in between rooms that he actually pulled me aside and told me that little bit of history.
Just one more quick thing. Of course, history is very important for the diagnosis, like you very nicely highlighted. The other part of the history should also be to understand the effect of the disease and the treatment, more so the treatment on the patient. Sometimes, we cause more damage to the patient with our treatment than the disease itself. So I think that's another aspect.
Yes.
And like you mentioned about this, the most common history that any ophthalmologist asks a patient of uveitis is, do you have joint pain? I have made it a dictum in our OPD that there is nothing called as joint pain unless you specifically ask for a history of inflammatory joint pain, which is more in the morning, disappears. You are not using the word joint pain in my OPD. So, I think I wish there was some general ophthalmologist sitting here. This could have been useful. Thank you.
Thanks a lot. Thank you.
So if there are no questions, we'll move on to the next talk. We have the next talk by Dr. Partho Pratim Dutt Majumdar, who is a uveitis consultant at Shankar Nethralaya, and he'll be speaking to us on clinical evaluation must-dos.
Good morning, everyone. First of all, I would like to thank the organizer and Dr. Basu for including me in this wonderful symposium. So my talk is on clinical evaluation must do. Slide, sir. It's not showing. Yeah. I think, so I'll be careful. So clinical evaluation must do. So I have prepared this talk mainly for the general ophthalmologist. So no, it's working, coming actually. Okay, I'll try to. I just hold it like this. So when we talk about clinical evaluation in uveitis, it's like, yeah, that's what I was thinking. Let me just give it a try. So clinical evaluation uveitis actually comprises of. It won't work. Yeah. I think some problem with the connector. Yeah, that's what. No, it's working from here, but the connector.
We keep going off when you are talking.
Yeah. Let me try. Yeah, like this. Okay, can I ask the next speaker to? I think, yeah.
See the conspiracy
Take your time. He needs a pen drive. So, you need a.
No, I gave him a pen drive actually. So we have Dr. Shishir Narayan, and who would be speaking to us on imaging essentials in uveitis.
Hi, thank you, Manisha, for asking me to give this talk. Actually, it was supposed to be Professor Vishali, who's an authority in imaging in uveitis, and we all look forward to hearing her talks, but unfortunately she couldn't participate, and Somvya and the faculty asked me to take over. So I'll try to justify this, and I'll quickly go over those slides which were meant for the general ophthalmologist, and probably we can spend a little bit more quality time on some slides which even I sometimes refer to when I have to make a diagnosis. So it helps me, revising this, some features. So we'll go over this. Just that more recently, we started taking a lot more photographs of the anterior segment as well. And I and Soumya were last week involved in a debate with the pulmonologists, and I've started sending photographs of this kind to the rheumatologists and the physicians so as to convince them that we are dealing definitely with a granulomatous uveitis and they can't turn their head away from that. One passion with me is photography, and that's the art of uveitis. So this is a photograph of the pars plana showing very elegantly using the steering technique to use our ultra wide field to demonstrate. And I had put it in one of the photo competitions also. And I've actually done fluorescein angiography of the pars plana as well, and able to document neovascularization. You know, it's very important image everybody has, but the time that you require now to spend with an image is very important. This one frame actually is telling you the entire story. So you have a macular edema here. You have an active area of vasculitis here. You have collaterals here. So that means that is the area that had retinal vasculitis, got compensated, right? These are the CNP areas. And traditionally, we always believed that the macular edema was from prostaglandins. But you see here, the VEGF being produced from this is causing the macular edema coming here. So there is a school of thought that not only are we looking for neovascularization, but treating the periphery and decreasing the VEGF load in this eye is actually going to decrease the macular edema as well. And I am one of those who believes in that. Again, is the time that you spend, you want me to do the same thing? Go and put it on a pen drive? Okay, I fixed it. So since the amount you spend with one image and the interpretation that you have is what is very important. So this is one STOCT. You can see here in the lower photograph that there is a complete loss of choroidal tissue and the inner retinal layers are totally gone. So if I had an image like this, I would not treat this patient at all from ocular point of view. So now you concentrate on this photo. You have a section here, which is completely normal. You have an EDI, which is showing thickening here. You have an area where it is already atrophic, and you have an area where there is an active inflammation. So this is the area that you are going to concentrate, and that's what you want to salvage. So when you see an image, it's important for you to see what you actually want to treat. It's not the macular edema alone, but probably subtle findings that you're looking for. Another area, and you know, when I was making this slide yesterday, I've got it for years, I've been making this presentation, but it's very interesting. So you see, just concentrate on these names of the white dot syndrome. They are only a technical description of the clinical scenario, some point, multiple evanescent white dot. What does it tell you? There are some white dots which disappear. It does not tell you anything about the condition. Multifocal placoid epitheliopathy. Of course, this one at least tells you that it is at the level of the epithelium, but it is only giving you a morphological appearance, serpiginous, serpentine choroiditis. So, punctate. So, it's just nothing. The reason is we never understood anything apart from the clinical picture and how it behaved with treatment. And this was what we all as fellows had to see, learn, and whenever we had in our busy OPDs, we would refer to this thing, early hypo, late hyper, we all know about it. But with the coming in of multimodal imaging, the whole game has changed completely. And why you want to do an investigation in a particular condition becomes important. So let's have a look here. So this is a pic. This is one fresh lesion. This is one old lesion. And what we have here is a clear-cut localized defect over here. What is important is that pic by itself does not require to be even imaged. When we are doing an image, we are actually looking for picking up an inflammatory CNVM. Apart from that, the indication for doing imaging in PIC would be rather little. Look at smears, for instance. So we have these white dots, and now when we do the unfast, we can see actually two types of red dots. One is at the level of the ellipsoid and one is in the outer nuclear layer. So this is one of my patients. So you have the multiple white dots. Earlier, we were always trying to explain this ICG. Where is all the inflammation? How are these hypocyanescent spots there? Plenty of cyanescent spots which are not there, seen on the FFA and seen more elegantly on the ICG. But look here, the pathology is only over here and the choroid is absolutely normal. So when we go in more detail, we see, we now do multimodal imaging. We are seeing the pattern ERG and the EOG. So here, if we go into more detail, we see here the ONFAS. This is in March and this is in June. They have completely disappeared, keeping to the true name of focal, this evanescent dots, that there is no significant change at the level of the choriocapillaris. So basically, what is happening is that there was actually a photoreceptor inflammation, and that is masking and creating those hypospots that you're seeing on the ICG. And there is absolutely nothing happening at the level of the choriocapillaris. And the small white dots that you're seeing, that is because of the changes in the outer nuclear layer. So now you can actually redefine this condition as a photoreceptoritis rather than a multiple evanescent white dot syndrome. Serpiginous choroidopathy, again, we have kept, with the keeping the general ophthalmologist in mind. You see that autofluorescence is more important than fluorescein angiography. The EDI is helping you to know the areas of activity, thickening. You can see the changes, and Octa is actually showing you the hypofluorescence. You can actually see that if the margin of ischemia that you see on the Octa is underlying the central area, then you probably treat this patient more aggressively. So the Octa is showing you what is not seen easily on either a conventional fluorescein angiography or clinically. And when you treat them with or without anti-tubercular treatment based on along with steroids or with Ozdex based on the other findings, you are able to salvage the situation quite well. And even the Octa shows a complete resolution. What is very interesting is that we were missing certain other features of the sequelae. So here is a patient, a paper showing you a CNVM of serpiginous choroidopathy. I will share one patient who has been coming to me since 2011. So you have this patient here, and at that time, autofluorescence had just come out. I was very excited, and I didn't do fluorescein angiography for this patient. So this is 2011, and you can see here, this is the already affected eye, and this is the lesion here. By 2014, this lesion had grown a little bit towards the center. And you see by 2015, I was always considering this as a recurrence of the serpiginous choroidopathy and kept him on Azoran. In 2016, he presented with a small hemorrhage. And now it became very clear that this is not a recurrence of serpiginous choroidopathy. Probably this is a CNVM at the edge of a choroiditis. After 5 years of following up this patient with documentation, to some embarrassment of mine as well, and you can see the fluorescein angiography is showing that there is a leakage here with more increase. And this is a very unconventional kind of a CNVM. Just then the Octa came. We got the Octa and we clearly showed a BNB sitting there, gave him 2 intravitreals, and since 2016 he has been absolutely quiescent. So these subtle CNVMs we were missing because we were not spending enough time for multimodal imaging or looking for the finer aspects of complications. So really what has happened is APMPP is very interesting. So we have early hypo, late hyper, and we all are looking at AMP. I'm happy that there are retinologists here who also by default are doing uveitis, but there are some who do uveitis and retina by default. So you see, if you look at the AMP, again, this is a focal lesion, which is showing you a hypo perfusion. And when you do a point registration, you actually see that there is a focal area over here, and there is actually a flow void here. And And basically what really happens is when you do the fluorescein angiography, this is masking the initial hyperfluorescence, and then the leakage and staining is what is showing. So basically what we were earlier looking at and giving a morphological diagnosis, we can actually see the AMPI lesion as an area of focal ischemia within the retinal pigment epithelial area and in the choriocapillaris, and its changes at the level of the RP can be elegantly studied and interpreted in the light. I think VKH is again another interesting scenario, and we do make mistakes, but you can, Octa is again very helpful, and it's again very helpful to differentiate. But what is very important is that we can spend some time, but I think that would be overkill. What I just want to show you is one interesting case. Maybe we can ask our friends what they think. So this is petechial hemorrhages here in the macula. So we have a CNVM that we know. Now look at the angiography. We have put the multimodal imaging here. So you can see two areas of hyperfluorescence. You can see a CNVM over here nicely, and you can see a fluorescein angiography with leakage. And you see a CNVM here as well. What's the take? CSR or VKH? So we have petechial hemorrhages. I'm showing you that there are leaks in the left eye. So you see the vascular network very elegantly. Fellow eye has all this. You look at it very carefully. These are all smokestacks. Yeah, so this is a CSR. So pachychoroidal CNV, and there is a subtle CNVM in the other eye as well. Now there is a debate that we'll leave to the other session that's going to happen at 11 o'clock, whether we want to give an intravitreal anti-VEGF in BVN when there is no fluid or leakage. So that's not for this forum. So you see ICG, and ICG is showing you again those hypercyanescent spots and the features that are helping you to differentiate. So basically, Octa is the game changer and STOCT is a game changer. And earlier we used to learn this chart of white dot. It is actually changed to a chart showing the pattern of Octa and MMI, and that all the conditions that are happening at the level of the RPE can be understood more elegantly with that. So actually this is thank you written artistically. So thank you very much. I think it's gone off on its own. Thank you very
so
much for your time.
Any questions from the audience?
I won't be able to answer them.
So thank you, Dr. Shishir. And I was also expecting, being a Sunday, you said you have a passion for photographs. I thought we'll get to see your vintage car as well.
Yeah, that's next Sunday. I'm doing a drive in Nizamuddin East. You're welcome.
So now we'll move on to the next talk, the previous talk by Dr. Partho Pratim, and I think he'll continue on his clinical evaluation must-dos.
Let's wish me luck. Okay, so I'll be talking on clinical evaluation in uveitis. So broadly, we evaluate a patient of uveitis in our day-to-day clinic in 3 steps. So in the next 12 minutes, I'll just try to share some useful clinical parts on this. So what we do, we evaluate the anterior segment. We take the help of slit lamp, gonioscope, and we do applanation tonometry. Secondly, we do a biomicroscopic examination with 7890D. And we do indirect ophthalmoscopy, and based on that clinical finding, we try to evaluate them. We take the help of ancillary imaging, and then we try to reach the diagnosis. The next one, which is often discussed in various meetings, that evaluation of various system is very important part of a uveitis practice. But what happens, as Dr. Mayur has shown, that we take the indirect evidence. We ask the patient leading question and try to rely on the visible clinical signs, because sometimes it's not possible to examine this various system in our OPD. And sometimes based on our clinical suspicion, we also take the help of some imaging like chest X-ray, HRCT chest, CT scan, MRI, and various other. So I'll just share some few pearls on slit lamp examination. So slit lamp examination, one should not actually reduce the intensity of the slit lamp beam, thinking that the patient is photophobic and won't be able to tolerate the bright light. So in this scenario, when you feel the patient is very photophobic, cannot tolerate the bright light, so one should not reduce the intensity of the beam. So if you reduce the intensity of the beam, you miss 1+ cell. I'm sure even with the reduced intensity, you won't miss 3+ cells. But if the cells are occasional or 1+, if you reduce the intensity of the beam, definitely you will miss. So ideal approach is to reduce the width of the slit lamp beam, so that as I showed in this picture, so that will help the patient to tolerate the light, and you will be able to examine the patient. So next point is that always try to examine the patient in diffuse light before slit lamp examination. What happens sometimes when you start examining the patient in slit lamp, you try to concentrate more on the cornea and anterior chamber and miss out some major clinical finding. And this is very true when you are examining a case of scleritis. As you can see here, you see the slit lamp view, and sometimes you can see, if you are examining the patient in diffuse light, you can actually find out the area of scleral necrosis. You can see a scleral nodule, so which can be often missed if you are directly examining the patient and not paying attention to the various quadrants of the eye in slit lamp. So secondly, another entity like brimonidine induced uveitis, which is characterized by anterior uveitis plus marked congestion or hyperemia in the fornices. So this can be missed if you are not examining the fornices in slit lamp examination. Secondly, if you like a sarcoidosis, you can see this kind of millet-shaped nodule, which can be seen in the conjunctiva. So you have to examine the conjunctival fornices very carefully. The third is, don't forget to do a gonioscopy, because in some conditions, like in Behçet disease, if there is a very trace hypopyon, you can see them on gonioscopy. Secondly, in a patient after cataract surgery, which is running a chronic inflammation, you can see a fine cortical piece, which cannot be seen in clinical examination under slit lamp, but gonioscopy can pick them up. Also, sometimes the nodules like Barlin nodules or the keratic precipitates can be seen in gonioscopy, which may not be present in the corneal endothelium. So next important thing, you must understand that counting cell not always count on the clinical diagnosis. One example is the HLA-B27. So whatever the cells is, if you don't pay attention to the nature of the aqueous you see in a slit lamp examination, for example, the fibrinous content of the aqueous is more important here than counting the cells. You have to remember the counting cells is only for the quantitative estimation of the inflammatory activity, which you can actually record and compare it on subsequent visit to monitor the progression of the inflammation. Second important thing is one should not confuse the pigments as cells, because what happens when we dilate the patient with phenylephrine, phenylephrine has a tendency to release pigments after the dilatation. Also in elderly patient who has been dilated after a long time, they tend to release a lot of pigments. So sometimes I see those patients, my residents are sending from emergency clinic thinking them as an anterior uveitis, so don't confuse them pigments with cells. Most important is here is that examine the patient before the dilatation of the pupil, because you have to see the iris pattern and nodules carefully. As you can see here, the first picture, you can see the clinical the iris atrophy, which is characteristic of viral uveitis. Look at the second two picture. These are the fuchs uveitis, which you can see the loss of fine pattern. The middle lower picture, you can see here, it is the moth-eaten appearance, which can be seen in sometimes the fuchs uveitis. Also, if you are examining the patient in dilated pupil, you miss the Koppes nodule, because if the pupil is stretched, like you see the next, the lower one, you can't appreciate the same patient's photograph. You can't see the Koppes nodules when it is dilated. Also look at the pattern, size and distribution of the KPs. As you know, the mutton fat KPs are characteristic of the granulomatous uveitis. The pigmented old KPs are often indicative of viral infection, and the stillet-like or the star-shaped KPs are star-shaped KP denotes the Fuchs uveitis. And sometimes you need to know the distribution of the KPs, which are normally arranged in a base down triangle. But when they cross the midline, there can be two possibilities. One is Fuchs uveitis, another is viral uveitis. So next time you see a diffusely distributed KPs in a patient of uveitis, think of Fuchs uveitis and viral uveitis. So don't ignore the red flag signs of uveitis. What are these? The red flag signs are the hypopion. If you see a patient with hyphema, you have to rule out the viral uveitis or severe nature of any uveitis or traumatic uveitis. Similarly, if you see the peripheral ulcerative keratitis or the necrosis in the sclera, you have to rule out the systemic disease, because this denotes that the patient may have some lethal vasculitis or systemic autoimmune disease, which are not only dangerous for the eye, also for the life of the patient. So you have to investigate them, refer them to rheumatologist, and save not only the eye, the life of the patient also. So fundus examination, coming to the fundus examination, you have to remember that even if you are dealing with a case of anterior uveitis, fundus examination is must. And don't forget to examine the periphery of all patients, because many conditions they can actually involve the periphery, like intermediate uveitis, acute retinal necrosis. Sometimes the serpiginous like choroiditis can begin from the periphery also. And as you can see, the other two, the peripheral toxoplasmosis, very rarely they can involve the periphery of the fundus. So another very important in our day-to-day clinic is trace the blood vessel. It will give the valuable clue and diagnosis. First of all, it helps you to differentiate between the choroiditis and retinitis. If you trace the vessel, you will realize that in retinitis, the vessels are obscure because the clinical lesions is just above the blood vessel. And whereas in choroiditis, you can see the blood vessel clearly. Next important is many vasocentric uveitis can be linked to these vessels, like cytomegalovirus. Sometimes in Chirolis arteritis, that can be seen in various conditions, including the toxoplasma, and various CRP. Choroiditis patches around the vessels can denote the tubercular vasculitis. And also sometimes if it is leaking or there is much exudation along the retinal vessels, then it can be due to sarcoidosis. So don't ignore any yellow color seen under the dense vitreitis. For example, I'll just give you some examples. Like if you see the dense vitreitis and you can see some exudate-like lesion in the inferiorly, think about pars planitis. If it is confluent areas of retinitis, then think about the viral retinitis. Single solitary patch, think with dense vitreitis, think about toxoplasma. Some same picture with a lot of band and traction to the ONH or the periphery, think about toxocariasis. Also, if you are seeing recurrent vitreitis in elderly patients, it's the time you have to do extensive evaluation and rule out conditions like intraocular lymphoma in these patients. Last, my point is intraocular optic nerve involvement. Considered it as an ophthalmic emergency. As you can see, optic disc granuloma can present like both in sarcoidosis and tuberculosis. Optic disc edema can be seen in sarcoidosis, VKH, toxoplasmosis, posterior scleritis, syphilis, and various other conditions. And if you see this juxtapapillary choroiditis, like here, you have to rule out 3T. What are these 3T? It is the tuberculosis, toxoplasmosis, and toxocara. Last, neuroretinitis. You have to remember that it is almost always unilateral, and it's a triad of macular star, optic disc edema, and unilateral vision loss. If you see neuroretinitis like picture bilateral, you have to rule out the other metabolic disease like hypertension, diabetes, retinopathy, diabetes. Now, coming to the system, you have to look for these signs, and you can get idea that what kind of disease you are looking at. Some necrotic digits can lead to can give you the idea that patient is having some lethal vasculitis. So I won't go into the details. I'll just conclude with a case. This is a 42 years old software engineer based in Canada. So he incidentally, when he started working from home, he incidentally noticed some floaters for 3.5 months. He went for an ophthalmic consultation there. He was found to have the left eye, some cells and vitreitis, and fundus fluorescent angiography was within normal limit. And he had some patches also in his, as you can see in the extremities ham. And so he was diagnosed as a VKH and started on oral steroids 60 mg and oral azathioprine for 3 months. There was no improvement in the floaters. So he just asked for a second opinion. So the patient was seen in our OPD, and after examining him, I asked the patient to come to the next day to examine the patient in undilated pupil. And as you can see, the patient visit to the next day clinic in undilated pupil, it showed the blurring of iris crisps. You look at the collarete area, the iris surface looking like a smooth velvet-like carpet. So this was a case of basically a Fuchs uveitis. So now what led to this misdiagnosis or confusion? Because the patient had anterior chamber inflammation in the left eye, and what was considered as a vitreitis was a vit debris and opacity, which is rarely seen in a Fuchs patient, which won't go with any amount of immunosuppression or oral steroid. And the patient had actually patches, white patches. And when I took the history, the patient informed me that it was there for last 15 years, much before the onset of the ocular symptom. So I just like to conclude with a quote from the famous samurai of Japan, that knowledge is not the power, it is the potential. Applying that knowledge is power, and understanding why and when to apply that knowledge is wisdom. Thank you.
Wonderful talk, Parthu. Just a quick question. What is the height of the slit beam that you keep during the counting of anterior chamber cells?
It's anterior chamber cells. We, as per as Sun classification, we keep a beam of 1 millimeter into 1 millimeter. But when we examine the other this thing, like one to photophobic patient, when I try to examine the like cornea and the other details, I just make a very narrow beam.
Okay, thank you. Any questions from the audience? Actually, I had several points, but I know we are running short of time, so we'll go ahead. Next speaker is Dr. Neha Mohan Jain. I'm happy to say that she was our fellow at LV Prasad Eye Institute at Bhubaneswar, and she will be talking on testing the tests in uveitis. How good are the tests that we do in uveitis?
Yeah, thank you, Dr. Basu, for giving me the opportunity to be part of this session. So we know that uveitis is actually a group of heterogeneous clinical entities, and the only common thing here is intraocular inflammation. As my previous speakers did justice to taking a detailed history, a clinical examination, and relevant fundus imaging. So these are actually the key features to diagnosis. Besides that, we actually have to delineate the disease in terms of course of the disease, telling the laterality, and then the anatomic location with some specific features. So do we really need a etiologic diagnosis of our uveitis? So for years, we have been pursuing this etiology and using a concept of idiopathic uveitis if we fail to. So what I may say in the next line may be a little mind-boggling, but it's a very interesting line that I read. So we have a child with idiopathic, we have a child with uveitis, and we are looking for a cause. And then we find that the child has JIA, and suddenly the idiopathic uveitis becomes non-idiopathic. But the disease that we found was itself juvenile idiopathic arthritis. So nothing is becoming non-idiopathic by finding an etiology. So the preferred concept of undifferentiated uveitis is what is now preferred. In fact, in one of the papers by Dr. Jabs, he says that the etiologic diagnosis of uveitis is actually a misleading concept. So what are the major hitches when we are thinking about what tests to do for a particular patient? Because no lab test is perfect. We may actually miss the diagnosis if we undertest the patient. We may overdiagnose and overtreat if we overtest the patient. And monetary consideration is definitely something in our minds. So before it gets too heavy on our heads, I would just like to highlight two cases. So we had this 19-year-old male who had decrease of vision since few months. Old OCT showed cystoid macular edema, and he had taken oral steroids for a couple of months, but currently they were not, he was not taking them. So this is the right eye and the left eye picture with vision of 6-9 paths and 6-9. So he had AC cells 1+ and grade 1 to 2 vitreous haze. The current OCT showed cystoid macular edema in right eye. He had few tests done already and nothing was suggestive, and we ordered few more tests to find that his serum alkaline phosphatase was raised. But the major finding was on CT scan. So I actually prefer a contrast enhanced, because in many presentations, I've heard the pulmonologist stressing on the enhancement rather than the high resolution, because they feel when the disease is active, these lymph nodes, they show activity. So this is my thing. So it showed mediastinal lymphadenopathy of 15 into 20 mm and paratracheal lymph nodes of 22 into 18, and anything which is above 1 centimeter, I do an EBUS because we need to sample these things. And this is what we found, that the child actually had Hodgkin's lymphoma, and a whole body FDG PET CT scan was done, which again showed another lymph node in supraclavicular region. So coming on to case 2, there was a 26-year-old male with decrease of vision in right eye since 5 days. His general build was good, and he said that he had some episode in the past, but with no clear-cut history. These are the pictures of both the eyes, and like Dr. Partho mentioned, that whenever we see a disc like that, a disc granuloma, the most common diagnosis that comes to our mind is either tuberculosis or sarcoidosis. Monto was positive 13 into 20 mm. CT scan was showing ground glass appearance with confluent fibrosis in the right middle lobe. Everything was going fine. HIV was negative, but suddenly TPHA turns out to be positive. We refer the patient to ID specialist, and there we also get history of painless genital ulcers. So I probably missed my history there, and CSF tap was done, and it was negative for neurosyphilis. So patient was treated with ceftriaxone because he was penicillin sensitive, and there it goes. Everything resolves beautifully. So I learned my lessons well. And so what is the purpose of lab testing? We surely don't want to miss a systemic disease that can have significant morbidity and mortality to the patient. We don't want to miss an infection whose treatment would otherwise treat the patient, and missing it would cause a lot of trouble to the patient. We also want to know the baseline parameters, because we want to start therapies for the patient and monitor the adverse effect of these therapies. The lab testing can be in the form of serological testing and molecular testing, but they are mainly into two categories. So screening means that if a patient has a particular profile like anterior uveitis or intermediate uveitis, we have a set of screening tests which we actually do for all the patients, because there are many diseases like syphilis which are great masqueraders, and they have multiple phenotypic presentations. Also, if the diagnosis is going to alter the treatment markedly from antimicrobials to immunosuppressants, we don't want to miss those diseases. And we also don't want to miss outliers like the patient of Hodgkin's lymphoma. Targeted testing is done when we tailor the approach as mentioned before, and only do the disease specific testing. So now starts the little difficult part, as in like refreshing our basics. So any test that we are doing, we want to know the sensitivity of the test, that if out of all the patients who have the disease, how many are actually going to test positive. Similarly, specificity is when we don't have the disease, how many actually are going to test negative. So if a patient, if a test has 99% sensitivity, that means out of 100 who have the disease, 99 would be picked up by a sensitive test, and there would be one false negative. Similarly, positive predictive value, that if the test is positive, how many are actually having the disease. And negative predictive value, that if the test is negative, how many actually do not have the disease. There's something known as pretest probability, which is actually the prevalence of the disease is a proxy to it, also along with the clinical features of the disease. So sensitivity and negative predictive value give us the false negatives. So let's imagine a situation where we have 99% sensitivity and we test. So if the sensitive test is negative, then practically we are ruling out the disease. So a highly sensitive test helps us to rule out a disease. Similarly, a highly specific test helps us to rule in a disease, because if the disease was not there, it would have negative, it would have been negative on the test. So if it is positive, that means the patient definitely has the disease. So coming on to some more common clinical entities. So initially for syphilis, we used to do the non-treponemal test, like we would order a VDRL. But VDRL actually only has 70% sensitivity, which means that 30% positive syphilis is getting missed by a VDRL test. So that brings us to the concept of reverse screening, where we actually do the treponemal tests first. And there, these tests are highly sensitive and specific to pick up the disease. But the problem is that they do not differentiate between a treated disease and we cannot monitor the disease response. So after we have done a treponemal test, we do a non-treponemal test because it monitors the disease activity. So because I found it very relevant, so I have little combinations. First, we do a treponemal testing, and if it is positive, we do a non-treponemal testing. And if that is also positive, patient has active syphilis. But in case the non-treponemal test is negative, then we go for second treponemal test. And if it is positive, that means that patient either has treated or latent syphilis. However, if the second treponemal testing is also negative, then probably the first test was a false positive. So coming on to tuberculosis, unfortunately, most of the tests that we use for tuberculosis, they cannot differentiate between active, latent, or healed tuberculosis. Here we are using the immunoreactivity of the CD4 T cells to TB antigen. The most popular are the MON2 test and the quantiferon TB Gold test. However, the positive predictive value of MON2 is just 56.6%, while that of TB Gold is 91.3%. So recommendations say that actually the screening should be done with the TB Gold. So I think, go in a reverse order. We order MON2 and then we, if it is positive or doubtful, then we go for TB Gold. But we should actually prefer TB Gold, especially in settings where we have high suspicion of ocular TB. And even in healthcare workers who are at risk of it, patients with substandard housing conditions, and where we are considering immunomodulation. So because the ocular tuberculosis is possibacillary, so we have very low sensitivity to molecular diagnostic testings with PCR. Coming with ocular sarcoidosis, so we have a lot of clinical indicators for ocular sarcoidosis where we have mutton fat KPs and iris nodules, string of pearl opacities in the vitreous, candle wax strippings, and the international workshop on ocular sarcoid also gives us a lot of guidelines for that. So these are the 4 popular tests that we do for ocular sarcoid. Although gold standard is tissue biopsy, but in eye getting a sample is the difficult part. So we see that serum ACE has a very low sensitivity, and in fact, in combination with the lysozyme, the sensitivity reaches only 61%. And specificity 88%. So all these figures here are specific for ocular sarcoidosis. In most of the other diseases, we take an extrapolation from infectious diseases like syphilis and other rheumatic diseases. They are extrapolation of the data from rheumatology. But here, this is for ocular sarcoidosis specifically, and we see that the CT scan is very good test because it is sensitive and specific. So because of the variable prevalence of sarcoidosis, the following recommendations include that because there are different organ involvement, so we should target these organs for investigations if we are actually looking for sarcoidosis. And a chest radiograph or a tomogram along with liver enzymes and query for skin lesions looks quite sensitive for picking up ocular sarcoidosis. The HLA related disorders, so HLA testing is very sensitive and specific. So if you're looking for a particular HLA, you are likely to find that. But the point is that finding a HLA, does it really mean that the disease is because of that? So here we'll focus mostly on HLA-B27 anterior uveitis and Behçet's because that's more common. So HLA-B27, the high prevalence, the pre-test probability is very high, 19% in our population. So we may actually get HLA-B27, but it should be typically ordered in a clinical setting of unilateral, acute, alternating anterior uveitis. And if we do it in a case where there is a bilateral granulomatous, we have a chance of getting a positive result. So, but that is unrelated. And another reason for doing HLA-B27, sometimes we are clinically sure that this is HLA-B27 and we treat the patient on those lines, but yet we need to confirm it because we have the onus of referring the patient further to a rheumatologist. HLA-B51, the prevalence is variable throughout the world. being lowest in America, and in Middle East, it is quite high. So any result actually is of marginal benefit. If you look at the positive predictive value with 64, negative is 79. So we have false positive, negatives, it's really not telling us much. So here also, I think history of oral ulceration is said to be around 95% sensitive for Behçet's disease. So that is the diagnosis of Behçet's is mainly clinical with relevant clinical settings. Coming on, just a quick word on JIA. So JIA is this long list of different where we have ANA positive, RF negative scenarios. And ANA should be usually preferred in a patient who has oligoarticular disease. If you're testing it in a polyarticular JIA, it really doesn't help much. And RF negative GIA is more common than positive. So RF testing in polyarticular setting has a sensitivity of just 0.7%. So to summarize, the course of the disease needs to be outlined, the laterality needs to be outlined, and the anatomic location with specific features. And then we should have a profile of screening tests where we don't miss major systemic diseases and infection, and targeted testings based upon the pretest probabilities and the 4 criteria. So this is an interesting read who really want to play with the statistical values. And this is the table for various diseases. And here we can see that, only sarcoidosis and the infective varieties are the ophthalmic data. The rest are all extrapolation from rheumatology, internal medicine, and ID diseases. Thank you.
Thank you, Neha. That was very fast and very well covered. I think the summary slide was very nice, but we need to rush to the next presentation because the audience for the next meeting is already here. Our next speaker is Dr. Manisha Agrawal, a chair here, and she'll be speaking on treatment with corticosteroids.
So a very good morning to all of you, and thank you, Sao and Dr. Basu, for giving me this opportunity to speak on this topic. Though I took some time to understand what does it mean by saying managing smartly. So basically, what we need to understand that in uveitis patients, it is important that we do not allow these patients to go blind without a trial of steroids, because they play an extremely important role in management of any uveitic entity. The goals of treatment with steroids, once you have ruled out any infection or malignancy, ocular inflammation is the principal cause, as we all know, of complications in most of our uveitic patients. And the control of inflammation is the primary goal, and we have to do like a firefighting to control the inflammation at the earliest. The other goals, of course, being an early control of inflammation with minimal side effects to prevent damage to ocular structures and also prevent long-term complications such as a permanent visual loss. Now, various modalities of steroid treatment are available, such as the systemic steroids, a local steroid therapy in the form of posterior subtenon tricot. We have Ozurdex implant, and there are others also which are not available in India. But now people are also giving suprachoroidal triamcinolone deposits as a modality of steroid treatment. Now, what we need to understand is that there are basically 2 phases of treatment. One is the induction phase and one is the suppression. And the induction phase, of course, is the initial phase of control of active inflammation, which is applicable to all the cases of uveitis. And we have to do it as quickly as possible. And there is absolutely no question that we have to use a full dosage. There is no point in treating it half-heartedly with steroids. As far as the suppression is concerned, we have to give a maintenance dose to control the inflammation in chronic inflammatory diseases after we've done a successful induction. And for chronic severe diseases, a long-term suppressive therapy is the key, because you may then land up with a very bad recurrence, which may be even more difficult to treat and control than the primary onset. So the indications for systemic corticosteroids would be a chronic bilateral disease beyond the anterior segment, The cases which are resistant to local therapy, eye diseases associated with systemic diseases, and severe inflammation that is too painful or destructive, we better resort to systemic corticosteroids. Now, this is a usual routine we follow where we initially start the patient on 1 milligram per kg body weight, and we go to a maximum dose varying between 60 to 80 milligrams. And of course, the tapering, this is what is described, but it also depends on the type of uveitis that you are dealing with and also the type of response you are getting. So it is very patient centric, and it may vary from patient to patient. As far as oral corticosteroids in children are concerned, we have to use a short-term course of oral corticosteroids, but it is advised not to put the children on long-term oral corticosteroids because they may have an effect on their growth. And it is better to shift them on early use of immunosuppressants, which Dr. Rohan is going to be highlighting in the next talk. Growth monitoring is very crucial when we are having children on systemic steroids, and generally such therapy would require a simultaneous evaluation by a pediatrician or by a rheumatologist. Now, this is one of our patients, a 61-year-old female patient having pain and floaters in the left eye for last 3 days. The vision was not much affected because the macular area was clear, but she did have a yellowish mass in the supranasal quadrant with a localized exudative RD, and dilated conjunctival vessels were present on anterior segment evaluation. And this is how it appeared, where you had RP undulations and you did have a pocket of subretinal fluid when we passed the OCT through this particular lesion. So we did a B scan, which was not very much suggestive of a significant T sign. And this is how this appeared on a fundus fluorescein angiography, where you do find element of hyperfluorescence, and you do have some mottled appearance of hyperfluorescence surrounding this particular lesion, which with a hyperemic disc, which does show that this patient was in fact having an inflammatory lesion. So the presumptive diagnosis of a nodular posterior scleritis with exudative RD was made, and all the investigations were done, and the patient was started on oral corticosteroids, and you see there was a beautiful regression of this entire lesion in the supranasal quadrant. This is a 24 years old female patient with diminution of vision in the left eye for last 5 days, already on ATT for last 2 months, and all the investigations were very much suggestive of Cox disease. And this is how she presented, where she had this huge granuloma in the supranasal quadrant with those typical petechial hemorrhages suggestive of the RAP lesions, with the involvement of the optic nerve head. And again, the OCT beautifully showing the choroidal granuloma. This patient was treated with intravitreal injections of Avastin and moxifloxacin along with ATT and corticosteroids. And we have done this study where we have measured the VEGF-A levels, which were extremely high in this patient. The patient responded very well to the treatment, but apparently developed a paradoxical reaction where you do see that there was development of a new lesion on the temporal side of the previously regressed lesion. And at this point of time, nothing else could have worked but for an IVMP, which was given to this patient along with stepping up of the oral steroids. So this is the timeline of this patient, where the patient recovered a vision of 6.6 N6 with complete regression. So the importance is that you have to recognize that you are dealing with a paradoxical reaction, and that is the indication for stepping up of your steroids. And since this was a macular threatening lesion, we decided to treat this patient with IVMP, and therefore we were able to get back a 6.6 vision in this particular patient. Now, coming to local steroid therapy, the indications, of course, are non-infectious uveitis in adults, pediatric uveitis, where we would like to avoid systemic steroids having an impact on their growth, the patient not responding to systemic therapy, and the contraindications to systemic therapy, such as pregnancy, diabetes, or psychiatric problems, where patients tend to develop secondary to a very long-term ongoing systemic corticosteroid therapy. And also, we have to keep in mind the side effects of local therapy, such as rise in IOP. So if a patient is having a history of glaucoma, you probably would hold your hands back from local therapy. And also, if you are dealing with a young patient where you have the risk of developing a cataract. So this is a young 33-year-old male patient with a left eye history of trauma with iron particle 8 days back, followed by diminution of vision, and underwent a corneal tear repair elsewhere. Diminution of vision was there in the right eye for 1 day, and the patient presented with a vision of 612 with AC cells. And of course, the diagnosis very much was of sympathetic ophthalmia in the contralateral eye. And when we did a fundus fluorescein angiography, you find these small pockets of leakage all along the posterior pole. And this is one of the rare and unusual presentations of sympathetic ophthalmia, where you may have only the involvement of the posterior segment. This is how the patient appeared on an OCT, where you had this huge pocket of the serous detachment. The patient underwent IV MP for 3 days, followed by oral corticosteroids along with azathioprine. And this is the timeline of the patient. At presentation, he had a 612 vision. And after IV MP and oral corticosteroid, there was a regression in the pocket of the subretinal fluid. But the patient really was not really having a complete resolution of this pocket. And therefore, we decided to give him an Ozurdex implant, which led to a complete regression of the serous detachment with a recovery of 6/6 and 6 vision. So this is another patient with pain and redness in both the eyes for 3 to 4 months, history of lymph nodes, diagnosis of multi-drug resistant TB was done 10 years back, and the patient had taken a treatment for 3 years with no response to treatment. The vision was 6/6 N6 in both the eyes. There was evidence of active inflammation. The patient was started on Visalon in tapering doses along with Lotipred topical steroids. The patient did undergo various investigations, and this is how the patient appeared, where you had all regressed lesions in the left eye. But in the right eye, the patient had these persistent lesions which were macular threatening. And since the patient was a young boy already having all kinds of complications secondary to the long-term corticosteroids in the form of developing diabetes and hypertension, the patient was extremely reluctant to continue taking oral corticosteroids. So at this point, we decided to give an Ozurdex implant in the right eye initially, and you find that there was a beautiful response to this Ozurdex implant, and subsequently the patient did develop some active lesions in the other eye and was injected with Ozurdex in the other eye with a beautiful response. So this is how we actually controlled this patient with the active inflammation threatening the macula and not really wanting to continue oral corticosteroids because of all the complications that this young boy was already developing. And this is a pregnant female, again, where our hands were tied, where we could not really give the patient oral corticosteroid despite the diagnosis of a VKH, which was really threatening her vision in the eye. And again, over here with much discussion with the patient, because it was an important pregnancy for the parents, we decided to treat this patient again with topical, with a local therapy in the form of an Ozurdex implant. And again, the patient responded extremely well. So you really have to see the risk-benefit ratio when you are treating your patients, whether you want to opt for a systemic steroid or you want to opt for a local therapy. So just to remember a few principles when you opt for steroid therapy in uveitis patients, and when we try to understand when and how to use them smartly, would be that you have to assess the type of uveitis that you are dealing with. You have to rule out infectious and malignancy as an underlying cause of uveitis, where the steroids may actually take you away from the actual diagnosis. You have to hit hard and hit fast. That means the induction has to be with a full dose of steroids, and you should avoid using a half-hearted dose because it is just going to lead to a more prolonged course of the uveitis. You have to do a maintenance with steroids or immunosuppressants in cases of chronic uveitis to avoid a bad recurrence in the later course of the disease. You have to use steroid judiciously with monitoring of the systemic side effects, especially in children and young patients. And you have to also decide for an early shift to immunosuppressants or local steroid therapy when you are treating children with uveitis. You also have to consider local therapy when systemic steroids are contraindicated, such as in patients who are young females who are in their pregnancy, or they are having a risk of developing diabetes. So I think that is what I wanted to convey, that you have to choose steroids which are important for treating patients of uveitis, but you have to use them smartly by weighing the risk-benefit ratio in your patients. Thank you so much for your patient listening.
That was a fantastic talk. Thank you so much. Unfortunately, we are not having any more discussions now. Last speaker today is Dr. Rohan Chawla from RP Center, and he'll be speaking on immunosuppressives and beyond.
Thank you, Dr. Basu. Thank you for including me in this session. Very nice talk, Dr. Manisha, and you have very smartly told us how to use steroids smartly. But then despite being smart users, there's a day when you don't want to use them any further. So that's what I'm going to talk about a bit. So about immunosuppression and beyond. So when do we start immunosuppression? Dr. Manisha has already highlighted a few things, especially the point about children. So to add to that, it depends on the primary diagnosis. Sometimes you can start them even as a first-line therapy, the severity of the disease, whether it is bilateral, and most importantly, the side effects of the steroids, and how frequent are the recurrences, and how much is your patient dependent on the steroid is what you need to assess. And even some local ocular side effects would want you to shift away from steroids sometimes, like development of a CSC. So in the textbook, these are some of the conditions which are given where you can even start immunosuppression at the day 1, because these are known to be very chronic and insidious with recurrent attacks, and patients are prone to lose vision. So just to talk of few of them: Behçet's disease, sympathetic ophthalmia, VKH, JIA associated uveitis, some of the scleritis conditions. And so here, even if you start them at day 1, it is quite warranted if you are definitely sure of the diagnosis. So just an example, case of sympathetic ophthalmia: one eye has trauma, a corneal scar, adherent glaucoma there, the other eye developing some subretinal fluid. So this patient, again, we treated with steroids initially and added immunosuppressants from day 1, and we have continued that for about now 5-6 years. And we have done a small study on cases of sympathetic ophthalmia, about 14 patients, and all of them we were able to maintain remission with steroids less than 10 milligram, and out of that 7 patients are still continuing on immunosuppressants. So this condition is one where we do not know actually where the end is, and some of them may require even a lifetime of therapy for that, and for that probably you need to add more than 50% of cases some sort of immunosuppressant agent. So this patient came to us with a very severe disease. Media is quite hazy. You can see there's a lot of congestion there, disc edema. There was some amount of exudative detachment. We diagnosed it as a bad case of VKH. Treated again with pulse steroids and added immunosuppressants from day 1. So you see slowly there is a resolution of the disease, and we start developing, getting these fibrotic pigmented bands there once the subretinal detachment subsides. So even such cases, we would like to maintain them again on a very slow taper of steroids and add an immunosuppressant. So these cases again may go on for steroids also at least for 6 months along with immunosuppressants. Now, another case where you see this sort of sunset sort of glow and these lymphic nodules or resolved hypopatches multiple in the fundus. Now, this is a condition which you would not like to have. If you have treated a VKH properly, maybe you can avoid a sunset fundus. So if this patient probably had had been treated with steroids as well as immunosuppression much earlier, maybe he would not have reached this stage. So you would want to start treatment early. Another condition, a bilateral disease where you see these multiple patches of choroiditis and they are sort of fovea threatening. So again, once they are fovea threatening, I can treat this with steroids and definitely it will subside like this. But what if the patient throws up an early recurrence and the next recurrence is right there, bang on the fovea? Then despite your steroids, there may not be a full recovery of vision. So in such patients, again, if you feel that our patient is having recurrent attacks and the attacks are closer to the fovea, I would not hesitate to keep them on immunosuppressants. Now, for how long is a different question, and I would address that subsequently. So another case here, already the patient has had multiple attacks. The right eye has a bad fovea here, bad visual acuity because of scarring. And now the patient has developed a very small subtle recurrence here in the left eye. So similarly in this patient, I would treat with steroids to immediately control the disease, but then put him on long-term immunosuppression. I do not want the patient to throw up a recurrent attack and again lose whatever vision he has in the better eye. Side effects, we do not want moon phases. We do not want side effects like this. Another child probably of sympathetic ophthalmia who's already been overdosed with steroids has to be put on immunosuppression. The other thing is a patient is having very frequent recurrences, more than 2 or 3 times a year, and is steroid dependent. So this patient had this choroidal granulomatous sort of lesions. And this patient we had diagnosed as ocular sarcoidosis would definitely improve once you give steroids. OCT shows you this nice silent like granuloma without any inflammation going over into the retina. So once you treat them with steroids, yes, there is resolution of granuloma. The lesion also becomes a little subtle. But then if the patient is having more than 2 or 3 recurrences a year, how long will you again continue going from 60 milligram down to 10 milligrams? So again, you start them on immunosuppressants and keep them on for that for 2 to 3 years. So what what Foster says is that you must keep them on immunosuppressants for at least 2 to 3 years once you have taken a decision to start immunosuppressants, and then only maybe you reduce it a bit and then stop it. There is no concept of a slow taper like that in steroids, but yes, some of us yes do tend to reduce it a bit and then totally take it off. So when are steroids alone sufficient? If you are able to maintain a long-term remission without steroid medication, only once or twice, maybe in few years, and if you can maintain a patient on less than 10 milligrams of steroid, you can again keep them on steroids. And if you are unable to regularly monitor for side effects of immunosuppressants, you can keep them on steroids alone. But other than this, there is an alternate view of Stephen Ryan, who says that put all patients on immunosuppressants, because he says that a long-term remission will only occur as a consequence of resetting or re-educating the immune system, which the steroids will not do. They are very good agents to suppress the inflammation, but they will not reset the immune system. So as per their school of thought, they probably put most of the patients on immunosuppressants, keep it on for 2 to 3 years, and they emphasize on a steroid-free remission. So that is one concept if you want to follow that. But in our country, and considering our patients who may not be able to get all the investigations all the time, and we are prone to infections in our country, so probably we don't follow it, and we follow the other part which I talked about earlier, where you start them when they are steroid dependent or they're having side effects of steroids. And also remember that despite immunosuppressants, you may never be able to have a patient who's fully off steroids. So it's a combination of less than 10 milligrams steroids and an immunosuppressant sometimes. And maybe in their country, what they do is they start 2-3 immunosuppressants, or they add the biologics, and then they are totally able to get a steroid-free remission. But that again may not be possible in our country because of cost considerations and infection considerations, testing possibilities. So I would still say I would be happy if I can maintain a patient. Number one, yes, no steroids, only immunosuppressants, a chronic patient. Or even if I can maintain a patient on, say, 7.5 milligram Visalon and 1 immunosuppressant without disease activity, that is also, I would say, a good outcome for the patient. So have there been studies showing safety of immunosuppressants? Yes, a site cohort has shown that the cancer-related deaths were not increased by the dose of immunosuppressants that we use. Then there have been studies which have compared, like Dr. Manisha was talking about, local steroid therapy. So compared the local steroid implant versus the immunosuppression, and they've definitely found that systemic complications were low and similar in both the groups, and ocular complications were more in the implant group. So again, you can say that these systemic immunosuppressants are safe to an extent, and like Dr. Basu said initially, always see if your therapy should not do more harm. So you have to balance that also. In a mild disease, why go for these agents? But yes, when you require them, you can give them, and studies have proved that they can be safely given for a long time. So which drugs to use? I think I'll skip that for sake of time. These are the common ones which we use. Just one point to highlight for azathioprine, which is an agent which I commonly use. Well, in Western countries, and even I think in private practitioners, many of them are getting this TPMT level done before starting the drug, because some patients who do not have this enzyme can have a drastic fall in blood counts. But in our setup, this is a very expensive test. I'm not getting it done. So what I do is we give a trial dose of 50 milligram, a low dose 50 milligram for 2 weeks, repeat the hemogram within 2 weeks. If it doesn't show any precipitous fall, then this patient probably has the proper enzyme level, and I can then escalate the dose to and go up to about 2.5 milligram per kg. But this is the safest drug in pregnancy also, if at all you want to give immunosuppressant. Methotrexate has a good safety profile in children, and the only concern is that if you go above a dose of 15 milligrams, sometimes the bioavailability is not good, and if you feel the response is not coming, better to shift to a subcutaneous injection and go up to the dose of 25 milligrams, because that is what generally helps. Again, with these immunosuppressants, the problem is some of us tend to hold our hand and say, okay, let's give a lesser dose, but then that does not work. Let us go up to the, maybe if not the maximum permissible dose, optimum dose is a little on the higher side only then you will get the response. So if which drug is better, there have been some trials for that between methotrexate and mycophenolate. So studies have not found any particular one to be very superior. So it depends on you. You if develop an experience with a particular drug, that becomes your preferred drug. So we have also tried intravitreal methotrexate in some cases. We gave a thesis there. So we found that it does help, but its efficacy is definitely much less than intravitreal steroids, and the duration of action is less, only about a month or 6 weeks or so. So when do I use it? Well, these are the complicated cases who have uveitis and glaucoma. So then it becomes a problem. What do you have to give? So if the patient has an acute recurrence, then I just give an intravitreal. It will bring it into remission for a while, and then I back it up with my systemic immunosuppressants. Apart from immunosuppressant, what are the other agents? There are a lot of biologics now. The story started with infliximab, but that, because of the IV administration problem, has now taken a back seat, and most of us have shifted up to adalimumab. It has this loading dose, and there have been again studies on this which have shown it to be effective to help reduce the dose of steroids less than 10 milligram, and it has shown very good favorable outcomes even in GIA. Then comes the TNF, the IL-6 inhibitor, tocilizumab, which all of you must have heard in the COVID times. So that also has found to show good effect in uveitis. But there is a study called aptitude study, which did not find it to have a benefit over than other TNF alpha drugs in GIA. So even in GIA, still probably adalimumab, a combination with methotrexate is probably the best thing for a chronic resistant or case which has multiple attacks. Another agent is rituximab. I have not used it very often, but yes, people have used it and shown very good effect in various types of uveitis, as has been mentioned. But problem is it can have some infusion related reactions. And most of the textbooks would say that use it as a third line agent if nothing else works. But it also has shown good effect in primary vitreoretinal lymphoma, whether given systemically or even in intravitreal form. So this is a new class of drugs, JAK inhibitors, which inhibit signaling molecules to various cytokines, and they looked very promising because they can be given orally. And I also thought of shifting some of my patients on that. But then there is now a FDA black box warning recently, which says that these increase the risk of chronic heart disease and cancers. And I would like to hear from Shankar Netrale their opinion, because I think they have been using these quite often. So how they have found it. So looking at their experience only, I thought I should also start using it. But with this warning now, I've become a little cautious, and I don't think I'll be using it that much. So the take home message is definitely, whenever you're dealing with uveitis, rule out a masquerade, rule out an infectious uveitis, and steroids are the mainstay. Start them with the full dose, start them judicially. Use a slow taper. Another mistake what we make is if you taper them very fast, you will get recurrences. So that is a problem. So go very slow, less than 20 milligram. You can even do a 2.5 milligram taper, depending on the severity of the disease. Maintain the patient on a low dose even for 6 months. If you can keep your patient less than 10 milligrams in remission, that's even a very good option. Otherwise, shift over to immunosuppressants and shift over early and use them again for 2 to 3 years. And you can also add on biologics if your patient can afford. Thank you. Thank you very much.
Thank you, Dr. Rohan. I think we have covered nearly all of uveitis in exactly the time allotted to us. We have not overshot our time at all. Unfortunately, we can't take any more questions here. Thanks for the next session, people to be waiting for such a long time. Thank you very much.
Thank you.
Without the presentation.
Can we all the speakers come to the podium for the mandatory photo? That's more important than the talks that we just heard. Yeah. I know. Thank you so much. No, it's. Thank you so much.
1 minute. Yes.
That's the informal one. Everybody can smile.
We smile in the formal ones.
No, you didn't.
Of course.
This chair was-
One important thing with the jack in between is the vascular occlusion. This one was good and that one was shining from.